Значи можем да започваме. Първо искам да благодаря на професор Тончев за това, че благодарение на гранта за европейските научни мрежи и по-специално за темата невронауки имаме възможност да поговорим за окото и по-специално за ретината. Както е казал академик Пашев, окото гледа с ретината, т.е. каквито и функции да имаме други, ако ретината е увредена, нямаме вариант да имаме добро зрение. Така че грижата за ретината, която има 3 невронен строеж и на практика е единственият сетивен орган, при който 3 неврона са разположени толкова близо, представлява нещо като мозък. Зрителният нерв на практика не е нерв, е оптичен тракт, тъй като се състои от ганглийни клетки на трети неврон. Разбира се, днес ние сме направили много по-сериозна крачка напред и имаме доста познания както за структурната, така и за функционалната характеристика на ретината. И за това днес организираме един семинар, който е посветен на няколко много важни момента. Те са свързани основно с нашата хирургична специалност, т.е. с хирургическото приложение на различни техники и апарати с цел оценка на състоянието на нервната тъкан на окото. И разбира се, с зрителното възприятие, като наши гости ще бъдат професор Мари Жозета Синьон, която е един от корифеите на ретиналната хирургия в Европа. Тя, разбира се, вече е пенсионер, но това не ѝ пречи да бъде един от лекторите номер 1 и тя ще изнесе една пропедевтична лекция по какъв начин да подхождаме, когато искаме да получим качествена витреоретинална хирургия. Другият ни гост е професор Томас Конен. Той е поканен във връзка с това, че както пациентите, така и много колеги мислят, че в момента, в който се фиксира някакъв проблем в окото, това означава, че е решен целият проблем. Професор Конен е един от ръководството на дружеството по катаракта и рефрактивна хирургия и в последните години се занимава много с ефекта на едофлешките върху невроадаптацията и по тази причина неговата лекция ще бъде посветена точно на това. За да затворим цикъла, аз имам удоволствието да поговоря за нещо, което е абсолютно нова технология, а именно оптичната кохерентна томография. Оптичната кохерентна томография на практика е една микроскопия, която микроскопия осъществява визуализация на клетъчно ниво на ретината и на други очни структури. Нейното приложение по време на операция е уникално. Към момента ние сме единственият център в България, който има тази възможност. И единственият център в България, при който оптичната кохерентна томография е съчетана с 3D микроскопия. Ето защо за мен е огромно удоволствие да споделя с вас нашия опит как да имаме полза от така нареченото IOCT, което всъщност е интраоперативно OCT. С оглед на това, че при нас има доста чуждестранни студенти, съм оставила презентацията съвсем умишлено на английски език. For all colleagues that are speaking English, I am very happy to answer your questions after the presentation. The presentation is actually quite pictorial, so even if you have very limited ability to understand Bulgarian, you will be able to do so because I put lots of illustrations and lots of pictures. Искам да започна с това, че през 2015 година аз вече си мислех, че съм постигнала някакво ниво на съвършенство в хирургията и обучавах моите специализанти и докторанти в това по какъв начин да поставят своите шевове на 9/10 от 500 микрона, което е доста смело, особено когато става въпрос за използването на класическа микроскопия. Но като повечето хирурзи, аз твърдо си вярвах, че ние можем да постигнем такова съвършенство с помощта на стандартната биомикроскопия. Какво се случи през 2020 година? През 2020 година, разбира се, всички ще я запомним с пандемията от COVID-19, като тази пандемия ни постави в доста екстремни условия. Тя ни накара да мислим за неща, за които ние не се бяхме замислили, за това по какъв начин да се предпазваме работейки и как да предпазваме нашите пациенти. И всъщност се оказа, че технологията с помощта на стандартната микроскопия, освен всичко друго, може да постави под заплаха нашето здраве. И 3D технологиите като че ли се оказаха доста по-ефективни по отношение на лечение. Но тук има един голям въпрос. Има ли смисъл наистина от асистент, интелигентен асистент по време на оперативната интервенция? Прилагането на изкуствен интелект, нещо, което IOCT ни предлага, дава ли ни някакво предимство при конвенционалната ни ежедневна хирургия? И бих искала да започна първо с предносегментната хирургия. Там ние разполагаме с едни изключително финни структури, които са подредени в слоеве. Те могат да бъдат подредени регулярно и това осигурява правилното пречупване на светлината и добрата невроадаптация. Но те могат да бъдат и обект на резки и внезапни промени, които могат да настъпят наистина в рамките на часове. И така, в момента, в който ние тръгнем да извършваме една оперативна интервенция, ни трябва да имаме не само начален план, но да имаме и възможност за модификация на този план. И не случайно IOCT или интраоперативното OCT се нарича още трета ръка. Защото то наистина ни помага изключително много в прецизността и в вземането на решения как, какво, къде и на каква дълбочина да извършим интервенция. Тук е момента да кажа, че имаме различен сетап за така нареченото IOCT, като то може да бъде две линии, това е демонстрирано тук, с определени размери. Тези определени размери ние можем да ги контролираме от 5 до 12 мм, т.е. на практика можем да покрием една значителна площ от очното дъно. С помощта на двоизмерното, т.е. изображението в две линии, ние засичаме информация, която е разположена в центъра на тези две перпендикулярни линии. По тази причина получаваме X и Y изображение и това много добре ни помага за двуизмерното възстановяване. Принципно това е интраоперативното OCT, което аз бих препоръчала да се използва от начинаещите, защото измерването в 5 изображения изисква малко по-голям опит. Какво може да ни помогне използването на интраоперативното OCT при една хирургия на предната очна повърхност? Там ние извършваме различни видове трансплантации, които могат да бъдат трансплантация на амниотична мембрана, пенетрираща трансплантация, предна ламеларна, задна ламеларна операция и не трябва да забравяме, че можем да обработим и травматичен случай. Именно по тази причина е важно в нашата практика да имаме нещо, което да ни дава наистина информация на клетъчно ниво. Тук е момента да кажа, че оптичната кохерентна томография ние сме свикнали да я виждаме в различни варианти. Един от вариантите за използване на оптична кохерентна томография е нейното оцветяване. Оцветяването като че ли изглежда много добре за пациента, то ни дава възможност наистина да му покажем нещата в цвят и повечето пациенти наистина са доволни от това. Но аз искам да кажа, че тя не дава допълнителна информация. Единствено има смисъл използването на цветно изображение тогава, когато оперираме с задно OCT и когато използваме стандартен микроскоп. При дигиталния микроскоп цветното изображение не ни дава по-добър контраст И това е причината, поради която цветното изображение се използва по-скоро с илюстративен характер. За разлика от него, приложението на стандартното черно-бяло изображение ни дава доста по-прецизна информация. Тук отново става въпрос за едно невродегенеративно заболяване, каквото е глаукомата, за което се налага да бъде извършена фистолизираща операция. Тази фистолизираща операция, разбира се, може да бъде извършена по най-различни начини, но за нас е важно в процеса на извършване на фистолизиращата операция да оценяваме позицията на структурите, върху които работим. В случая върху ириса, на който трябва да направим иридектомия. И по тази причина приложението на предносегментното OCT е от особено значение. По отношение на трансплантацията на амниотична мембрана, нашето звено е пионер в тази трансплантация и ние може да използваме мембраната по различен начин, като покритие, като запълващ елемент, техниката на Ханада, която е комбинация от тези двете техники, допълнителна хирургия и, разбира се, амниотичната мембрана е изключително подходяща при всички видове травма, било то с химически агент, с някакъв физически агент или просто механично разкъсване на очната ябълка с засягане на всички нейни нервни структури. Това, което можем да оценим определено много по-добре с помощта на оптична кохерентна томография е дълбочината на дефектите. И тук отново искам да потвърдя тази хипотеза, която изказах преди малко, че дълбочината на дефекта се оценява по-добре тогава, когато имаме двоизмерно OCT. Т.е. тогава, когато използваме оптична кохерентна томография с две линии. Следващият момент, върху който бих искала да обърна внимание, е именно използването на амниотичната мембрана като покритие. Тук виждаме един пациент, при който имаме десцеметроцелие. Десцеметроцелие, което се вижда, че е старо, защото има фиброза в зоната около десцеметроцелие. И в този случай се налага да използваме комбинирана техника. Както се вижда от отцветените оптични кохерентни изображения, с тяхна помощ ние можем наистина да определим слоевете, да видим тяхното разположение и да преценим коя от двете амниотични мембрани да фиксираме по какъв начин. Много често трябва да обърнем внимание на дебелината. Амниотичните мембрани могат да бъдат с различна дебелина. Но това, което илюстрира в конкретния случай оптичната кохерентна томография, е, че амниотичната мембрана на практика представлява 1/3 от това, което се получава след покритието при този пациент с силно изтъняла роговица след изгаряне с гореща линия. Така че оптичната кохерентна томография наистина може да ни помага изключително. По отношение на пенетриращите кератопластики, те са все по-малко популярни днес, защото все повече и повече минаваме към ламеларни техники. Тогава обаче, когато имаме непрозрачна очна среда, ние не можем да минем към ламеларна техника, защото не всички кератопластики изглеждат като тези кератопластики, които се виждат на илюстрации. В тези случаи, когато очната среда е непрозрачна, когато роговицата е плътна, ние на практика не можем да се ориентираме нито за това по какъв начин да разположим трансплантата по отношение на реципиентната роговица, нито можем да се ориентираме на каква дебелина слагаме шевове. И това естествено води до един нерегулярен, непредвидим астигматизъм и също така можем да поставим шевовете по начин, който на практика да затрудни оздравителния и възстановителния процес. Ето един такъв типичен пример на една пациентка с абсцес, на която се налага да се направи трансплантация по спешност. И това, което се вижда, е на практика, че има иридокорниален контакт, т.е. при нея е задължително да извършим отстраняване на този шев и поставянето на вискосубстанция преди продължаването на хирургическата интервенция. Бихме могли наистина да оценим шевовете шев по шев, да оценим камерния ъгъл, да видим имаме ли синехии в камерния ъгъл, нещо, което е бич за всяка една кератопластика. Включително бихме могли да видим, че имаме и възпалителни елементи, които са останали от предхождащата кератопластика. Това е една много показателна картина, която показва, че можем наистина да видим онова, което с око не се вижда, а именно, че ири се е захванат в един от шевовете. И сега е момента този шев да бъде сменен, т.е. това наистина е нашата трета ръка, нашето трето око, защото този шев може да бъде сменен и респективно това ще подобри прогнозата по отношение на възстановяването на пациента след пенетриращата. По отношение на ламеларните техники, те са сравнително нова техника в нашата операционна и там имаме много изисквания. Първо, тогава, когато искаме да направим задна ламеларна кератопластика, трябва да имаме изчистено роговично легло. Трябва да можем да оценим каква е позицията на самия трансплантат. Трябва да можем да го намерим, защото понякога трансплантата се скрива от нас. Трябва да можем да определим позицията на трансплантата и да вземем решение кога се налага да поставим допълнително. Ето един такъв типичен пример, когато си мислим, че сме направили пълен и хубав десцеметрорексис, но се оказва, че имаме остатък от десцеметровата мембрана в тази зона. Това е точно тук в тази вертикална зона. И в този случай оптичната кохерентна томография ни е изключително полезна, за да направим правилната стъпка, подготовка за въвеждането на трансплантат. Другото нещо, което можем да видим, са малки зони, като ето тази тук, в които са останали малки езичета от самата десцеметрова мембрана. И възстановяването на тези малки езичета наистина има значение по отношение на плътното прилепване на трансплантата. Разбира се, изключително важно е да бъдем сигурни, че сме почистили всичко така, както трябва. Включително би трябвало да бъдем сигурни как сме полирали балмоновия слой, защото за възстановяването след това има огромно значение. Тогава, когато извършваме една операция, при която не трансплантираме задна ендотелна мембрана, която се нарича DLEC, т.е. при нея само извършваме заден капсулорексис, без without ендотелиална трансплантация. В тези случаи можем да добавим амниотична мембрана и отново нашият оптично-кохерентно-томографски контрол е от особено значение. Сега това е пример за това какво се случва след като сме имплантирали трансплантата. Тук виждате, че окото е в доста голяма хипотония. Аз съм извършила инжектирането, роговицата е с доста нарушена прозрачност. Пациента има задна камерна леща, която частично е в предната камера, ето тук се вижда нейният тръп и всъщност съм зашила, за да не излезе моят трансплантат. Ето го трансплантата. И това, което виждам в момента е, че трансплантата ми е обърнат обратно, защото през тази помътнена роговица аз не мога да видя крайчето на трансплантата по абсолютно никакъв начин. И следващата стъпка в тази операция е аз да вляза и с помощта на една струйка от физиологичен разтвор да обърна позицията на трансплантата преди да инжектирам въздух. Ето вече трансплантата ми е в позиция, която е почти нормална, извинявайте, ето тук, но все още не е фиксиран, защото въздушното ми мехурче все още е много малко. И ето това ми е въздушният мехур. Локализирайки въздушният мехур, аз мога съвсем спокойно да вляза и да увелича неговите размери с цел да мога наистина да апозиционирам дълбоката мембранна. Така че според мен приложението на интраоперативното OCT, ние вероятно ще го видим и в презентацията на професор Симеон, е абсолютно незаменимо по отношение на извършването на ламеларни техники. Както на задни ламеларни техники, така и разбира се на предни ламеларни техники. По отношение на травмата, бих искала да кажа, че травмите в миналото ние сме ги обработвали включително и с очила. В последствие микроскопите бяха сериозен напредък. Днес травмите ги обработваме с операционни микроскопи, в които имаме оптична кохерентна томография. При оптичната кохерентна томография може да ни помогне във всички аспекти, както на предно-сегментната, така и на задно-сегментната томография, като тя може да ни даде много по-подробна информация за това колко са увредени тъканите, защото не винаги едно око, което изглежда по този начин, е със силно увредени тъкани, тъй като линеарните разрези на практика могат да се възстановят доста често. Дава ни информация за дълбочината на уврежданията и, разбира се, ни дава една прецизност при обработката, която не можем да си позволим. Ето един такъв пациент. Това е пациент, който е опериран за глаукома, но на практика, когато аз го видях за пръв път, аз не знаех, че той е опериран за глаукома. Това, което се вижда, е, че ирисът му по някакъв начин е излязъл извън окото. Всъщност това е така, защото този пациент тук в тази зона на практика е имал трабекулектомия. Това нещо може да се види много по-добре с помощта на оптична кохерентна томография. Благодарение на асистенцията на оптичната кохерентна томография, така изглежда пациента след отстраняването на помътнената леща, ексцизията на ириса, малка иридопластика и имплантацията на заднокамерна вътреочна леща. По отношение на перфорациите, това е една изключително тежка и неприятна патология, защото в момента, в който имаме заплашваща перфорация, заради характера, по който са структурирани очните банки в България, ние не винаги можем да имаме подходящ материал. Много често се налага да запушим отворите, които са се получили с помощта на трансплантат. Трансплантат, който на практика трябва да бъде фиксиран по някакъв начин, и трансплантат, зад който, тъй като той е полупрозрачен, ние не виждаме нищо. Много е важно да бъдем сигурни, че при фиксирането на този трансплантат нямаме тампонада на ириса, защото това ще доведе до тежък деформитет в предния очен сегмент, а също така и до повишаване на налягане. Не на последно място, ние сме институция, която се занимава с обучение. По тази причина бих искала да кажа, че оптичната кохерентна томография, заедно с триизмерната хирургия, е абсолютно незаменимо средство за извършване на обучение. Тук виждате част от нашия екип, който се обучава на симулатори. Симулаторите са много добър вариант, но симулаторите не могат да ни дадат онова, което ни дава реалната хирургия. Симулаторите са възможност да прецизираме своята техника, независимо от това колко добри хирурзи сме. С помощта на симулатори можем да се научим да извършваме определени движения. Тези определени движения обаче са по-реалистични, тогава, когато ги извършваме в един wet lab, и най-реалистични тогава, когато се извършват в реална хирургия. Оптичната кохерентна томография ни дава тази прецизност. Тя ни дава визуализация, с помощта на която наистина можем да прецизираме всяка своя стъпка, всяко свое действие. Освен визуализация, тя, разбира се, ни дава и контрол, ускорява процеса на обучение, осигурява едно по-добро разбиране за това какви са стъпките и какви са последствията в една хирургическа интервенция. И разбира се, тя е част от дигитализацията на хирургията въобще. Защото офталмологията няма как да избяга от дигитализацията в хирургията. Знаете, че роботизираната хирургия е хирургията на бъдещето и оптичната кохерентна томография по време на оперативна интервенция безспорно е нашето средство в това отношение. Тя може да се използва за такива съвсем елементарни неща, като, например, да видим докъде е проникнало едно интракорнеално чуждо тяло, както е тук в конкретния случай. Може да бъде използвана и тогава, когато пациентът е дошъл по спешност и се оказва, че в неговия трансплантат се е появила язва, но тази язва е много трудно да бъде охарактеризирана, поради това, че самият трансплантат е с доста увреждане. Освен това, тя може да бъде и една пътеводна информация, която да ни насочи по какъв начин да поставим нашия трансплантат, който е трансплантат на горещо в конкретни случаи, с цел наистина да оптимизираме намаляването на възпалението и подобряването на изтъняването. Не на последно място, с помощта на оптична кохерентна томография, начинаещият хирург би могъл да определи дълбочината на своите шевове. Би могъл да види точно какво прави, когато фиксира една амниотична мембрана. И това е нещо, което е определено препоръчително при хората, които сега тепърва навлизат в дебрите на офталмохирургия. Тук бих искала да направя едно лирично отклонение и да кажа, че малкият принц е казал, че това, което не може да бъде видяно с очите, може да бъде видяно с сърцето. Аз бих искала да кажа, че това, което не може да бъде видяно с нашите очи, определено може да бъде видяно с интраоперативната оптична кохерентна томография. Разбира се, като всяка методика, тя не е панацея, защото тя има определени ограничения. Едно такова ограничение е полето на виждане. Също така дълбочината и това, че на практика не бихме могли да видим една глобална картина и по време на операция ни се налага да включваме или изключваме оптичната кохерентна томография, защото нямаме автоматичен тракинг в тези случаи. Трябва да отбележа, че е много трудно да се работи с метални инструменти, защото металните инструменти имат доста изразени рефлекси и тези изразени рефлекси на практика затрудняват изключително много приложението на оптичната кохерентна томография по време на хирургия. Тя може да ни даде все още само качествена информация. За количествена информация няма да заработен софтуер. И разбира се, това е една технология, която все още е достатъчно скъпа и ни създава достатъчно неприятности като една скъпа технология. Защо оптична кохерентна томография? Аз лично вярвам, че това е прецизният начин да оперираме за бъдеще. Това е възможността наистина да бъдем уверени, че това, което правим, е това, което си мислим, че правим. По отношение на това, какво можем да заключим, използвайки интраоперативното OCT, определено това е нова играчка за нас, хирургите. Ние сме доста щастливи от неговото приложение, но все още има какво да се желае и по отношение на разработването на софтуера и по отношение на разработването на алгоритъм по какъв начин да прилагаме интраоперативното OCT. Нашата оценка за това, което виждаме, изисква наистина ние да имаме още допълнителна информация, която в момента се натрупва от всички потребители на интраоперативно OCT по целия свят. Безспорно, това е бъдещето. Безспорно, това е нашата алтернатива за извършването на роботизиране. В заключение бих искала да кажа, че COVID-19 промени изключително много нашата практика, но той ни накара, и да седнем и да се замислим по какъв начин бихме могли да оптимизираме. По какъв начин бихме могли да оптимизираме не само като количество, но и като качество това, което извършваме. Да направим оперативните интервенции така, че да викаме пациента по-рядко, и пациентите наистина да бъдат обгрижвани по възможно най-добрият начин. И това е нашия екип в условията на COVID-19. Виждате, че дори върху очила, 3D очила биха могли да бъдат поставени защитни шлемове. Изключително е важно да се отбележи, че офталмохирургията е екипна работа. Екипна работа означава, че в нея са включени както хирурзи, така и медицински сестри. Това е персонал, за който ние също трябва да мислим, когато работим. И осигуряването на психологическия комфорт на нашия персонал е от особено значение. Триизмерната оптично кохерентно контролирана хирургия е определено хирургията, която дава на нашия персонал първо възможност за дистанция, второ възможност за наблюдение и на практика участие в хирургията на повече от един човек, защото знаете, че всеки операционен микроскоп има два окуляра, докато в една триизмерна хирургия, дори при спазване на подходящата дистанция, ние можем да включим 3, 4, 5 участника. Така че аз твърдо вярвам, че това е бъдещето и съм абсолютно убедена, че с помощта на тази технология ние наистина можем да развиваме офталмохирургията в Североизточна България, офталмохирургията в България като цяло и разбира се на Балканския полуостров и в Източна Европа. С това аз бих искала да ви благодаря за вниманието. Аз уточних още сутринта, че можете да изпращате въпроси, като тези въпроси може да ги изпращате през чата, може да ги изпращате през различните комуникационни системи, които притежаваме и разбира се, можете да ги задавате и на живо, ако имате желание. Така, колеги, въпроси имате?
Благодаря, професор Грубчева. Аз бих попитал, всъщност, роботизираната хирургия в офталмологията, работейки близко до повърхността, колко е приложима? Мисля, какво допълнителна полза дава, когато се работи близко до повърхността, само по робовицата?
Роботизираната хирургия в офталмологията е все още много слабо развита. Причината за това е, че прецизността на роботите като такива, примерно както е с Да Винчи, не е толкова добра, че да може да се прилага в микрохирургията все още. Така че от тази гледна точка все още се работи и на практика няма Да Винчи за приложение в офталмологията или друг робот за приложение в офталмологията. Това, което ние използваме и наричаме роботизирана хирургия, са обичайно ендоскопи, които се прилагат за мини-инвазивна хирургия, за мини-инвазивна витрекомия, за мини-инвазивно извършване на циклодиализа и така нататък. Но това, което при нас е тенденция, е по-скоро един роботизиран контрол на самите хирургически интервенции. Тоест, с помощта на интраоперативното OCT ние получаваме прецизна информация къде да влезем и след това го правим мануално, като по този начин третата ръка, т.е. ръката на робота, на практика е ръката, която ни води, докато самата механична манипулация ние извършваме с стандартната техника, с която сме свикнали да работим. Или респективно я извършваме със съответното лазерно устройство. Това е, може би, една от стъпките, които ние ще предприемем. Въвеждането на фемтосекундния лазер като един изключително прецизен нож за извършването на различни хирургически интервенции.
Благодаря.
Колеги, ако нямате някакви въпроси, професорка Симеон ще се включи в 12 часа, което е 11 часа нейно време. Аз съм сигурна, че нейната лекция ще бъде наистина много впечатляваща, защото освен отличните си презентационни качества, тя има и невероятен опит. Така че това, което ще ни изнесе при всички положения, ще бъде много важно за развитието на витреоретиналната хирургия в България, защото тя не е особено добре развита. Във Варна ние тепърва правим първите стъпки в нейното развитие и много се надявам това да е една много стръмна крива на обучение, която да завърши наистина с ретинални операции с успех. Защото успеваемостта на тази хирургия не е от най-високите и на практика това е офталмохирургията, която най-често изисква реоперативно лечение. Така че ще се видим след 40 минути. Благодаря ви много. Hi, Marie-José, I see that you're already there.
So that is, you have already the sound, I guess, and now we need to have the video. Oh, I suppose I'm not so familiar with this this platform, but I suppose that I will find it somewhere. I do not have, I don't know why, but I do not have any tool. Okay. You hear me? You hear me, Christina?
Yes, I hear you. Hi.
Hi. But
Yeah, welcome virtually in Varna.
Yeah. Very good. But you don't see me, I guess, because I do not find a little tab where I can click on in order to have.
You see number of people, and then underneath you have a microphone, and then you have a video button.
Yes, but I do not have that video button. That is the problem. A presenter, I would like to make the presenter. That's fine. And then, okay. And then
Before share, you have no video button.
No, I don't have a video button. That is a little bit. No, what I can do is start again my link.
Yes, you can start again and start with, yes.
Yeah. Okay. I will click out because there is something wrong here.
Да, затворя. We see you now. But you need to unmute the microphone.
Done. Done. Okay. So now I suppose what I have to do is to see whether, when I share the screen, whether you have the presentation. Eh?
Yes.
We will do the try. Yeah. Okay. Okay. This. That should be the presentation. You have it?
We have a blank. Yeah, we have it now.
Okay.
Excellent.
I just have to increase to make the presentation active, and that's it. So now you have the big
Yeah, we have now. Perfect, Marie-José.
Okay, fine. So I think that we are okay. It's in 15 minutes, I suppose, huh?
Yes, it is. It is in 12 minutes now.
Minutes. Okay, very good. Okay.
So how is the weather in Belgium?
It's windy, very windy, but cold. It's getting colder. We have not much more than 8 degrees outside, and it is expected to be 4 degrees end of the week. So it's getting colder. I guess that in Bulgaria you have already colder weather.
We had snow from Monday to Wednesday, but at the moment it's about 8-10 degrees, so it's quite warm.
It's practically
-3 already, so.
Yeah. It's really it's getting winter, eh? Getting closer.
It does.
We will start in Belgium. We will start with a vaccination in January. So we will see what will happen. It is, of course, too early to see what will happen for the pandemic and what will be the effect, but we are ready to start in January.
Okay, excellent.
Yeah. And
I'm that we will start so soon, but hopefully we will start at some time.
yeah, of course, it will take time. So I think that, before everything will be a little bit the same like before, it will take 1 year more, I guess. And then we have to see whether the people will be so willing to travel again. Huh?
Yeah.
I'm not sure, I'm not sure about that. Maybe it will start quick, but we will see. So, in fact, I have prepared a presentation on the basics of vitreoretinal surgery, absolutely, but I will also focus on PVD and EVD, on some new issues, some new aspects that are coming up with the OCT, etc., mainly with the OCT during surgery. So I think that this is, I think that is important to know a little bit about posterior vitreous detachment and anterior vitreous detachment. Certainly for a vitreoretinal surgeon.
Yes. Thank you very much for this.
So otherwise, internationally, I guess it's quiet now, I suppose, for the EBO. It's getting a little bit better, I have the impression, the atmosphere.
Yeah.
Yeah. But anyway, when I think...
Siegfried wrote a letter to everybody that making this person in advisory board is not desirable, neither healthy.
Oh, wow.
I think that that was very brave from his side.
Yes, this is very brave from his side, because I must say that the way, again, that it was proposed, that is abnormal. You don't do that. It is not because, first of all, why to claim that you are the only person to have started the subspecialty exams? It was absolutely an idea from already many years before, but everybody thought that it must have been better prepared. And then it was started in a bad way. I don't know if you remember that. And that's certainly... And then that person who claims to be now, who is proposed by the president of the UMs to be the head of that advisory board, that is crazy. That she came for the ESCRS to look how it was done there, because she was a little bit desperate about the organization. And then you are going to say, that's the only person who can be the drive of that exercise. Crazy. But anyway, it's life is full of crazy ideas and crazy people who are still leaders. Let us think about Trump. Let us think about the UK. It's not much better there, huh? With Boris Johnson and the relationship between Europe and between UK. It's an exercise of so many years that finally is thrown away from the table just in a couple of minutes. Huh?
Yeah, but
yeah,
I find very amusing the way that it was said. I'm too old, so she must take my seat. So I offer my seat to her.
That's not what is done. That's never done. You can say I resign, and I would propose that you can propose it, but you cannot say I give it. It's not done. It's just not done. I was very happy with the attitude of Tero, who remains neutral, and corrected him by saying, it's not my work, it is a work of a team. And he reminds everybody that it is not only the work of Tero, but it was a collaborative conclusion. So that was already good. Now, I heard from Marco Paulina that he was proposed to become member of the advisory board by the next president.
Okay.
He was happy, and I think I would also say that it would be good to have Peter Ringens, because if he was not kicked out, Peter Ringens, there would never be such mistakes about the statutes and about whatever, and it would have been much smoother, because he had such a knowledge about the statutes and about the bylaws that he would always have said to the people, don't forget this, don't forget that. That is what he was doing all the time, that I was also, in my time even as president, he was so instrumental that he prevented me to make mistakes, because, you know, even if I also worked on the bylaws in my time, you don't remember it all the time. It's not in your head. It's not the only thing that you have in your head during your day activity.
Yeah. Well, I think that one of the big problems is the secretary in general at the moment, because Rimvidas does not speak English,
Yep.
and he's really like a puppet.
Yes, he is. He is. I know that from I know him from very many years, and he's very pro-Russian. When I start knowing him, although that Lithuania belongs started to be included in Europe, he was still very Russian. I don't mind. I like Russia and I like the Russian. But you know, you have chosen your country have chosen something, so orient you then to that. And he started very late. Yeah, okay. And I'm still not convinced that he's so immersed in Europe. I still think that his predecessor was much more than him. That was what is his name?
Yes, Pinkas.
Yeah. He was much more broader-minded person, much kinder, much opener. But yeah, you know, I don't think that he is. Just like you say, he's a little bit of puppet, and yeah, he's not very strong person. That's life. That's life. We do not have all the time the people we want in some positions. So
Yeah, exactly.
Exactly. Yeah. But I think that, yeah, we will see. You know, we will see. But I think that is extremely brave, what Siegfried said. So that means that Siegfried, if they didn't do it in Berlin, that is due to that same person. There was no support from the board. So I think that he was right. If you have no support, don't do it. That's correct. Even if he had you as support, but that's not enough. He needed the board, and that is what he was. But the EBU lost tremendous time due to that. Tremendous time. Due to that short-sighted mentality, but I think also the way that the current president of the UMs, you know, with a lolly on your screen, is that not a little bit childish during the meeting when you are president, and then asking all the time to help of Michelle Beaconsfield, who was absolutely not, she didn't know what it was about, the remark of Marco, and wanted to dismiss it by saying, you know, it's not done that you write a letter, it's just an observation on time asked by the president. Do you have remarks? Yes, he said, I have remarked and I have written it, but he cannot also explain it. And well, anyway, it's not good, you know, to have to polarize such a meeting and such a. Finally, it ended well, and I think that there is a new generation that I've seen that it's not bad.
Yeah.
That's not bad at all, but they have to learn it. And that is, I think, if I can give you an advice, Christina, and if you have time, is to send or to make a kind of summary of what is the task of the new incoming people. What is the current situation, short, so that they know a little bit more about what can they expect about their new job that they are. Because otherwise, you know, before you know a little bit of what is going on, having twice a year a meeting, it takes years before you know a little bit more about what happens. So if you could do a kind of a scenario of, or what do you say, the scenario and the book that is written from the scenario, so that they know a little bit more about the insights of what is expected from them, how it works, even if they have had the bylaws and the statutes, in practice, putting that in practice, it's quite difficult. Huh?
Yes, it is. It is. It is, and after all, it's absolutely clear that we can attract experts into the committees, and Sorka was actually very properly attracted.
Yeah, but Sorka is. Don't forget, Sorka. Don't think that she's still. She's a very broad-minded person, and she has a big heart, and she has a very warm heart. So she forgot about it. She will never forget about Gordana's attitude. That is something that she will never forget. That people can make mistakes, misinterpretation of the statutes, she can accept. That is something that we all do. And that is fine. And she got your excuses, fine, forgot. But that she was aggressed in such a way, that is something she cannot accept, and she will never forgive. Also because the person in question even didn't excuse herself clearly to her, personally. In such cases, you take the phone and you said, I'm very sorry, it was not my intention. I was a little bit excited, I was it was overdone, and that's it. And then it would have been cleaned, and then it would have been said, okay, I'm fine, but not the way that she did it. No.
Okay, Marie-José, I think that we should stop chattering, and I would like to introduce you to the audience. We actually have quite a few people. We have ophthalmologists, of course. We also have medical students that are having special interest. And Marie-José is one of the really very knowledgeable person about eye in general. And she has enormous knowledge about the retina, enormous knowledge about how the eye works. And actually, she is inventor and she has lots of patents. And she works on something which for me is extremely interesting. First of all, she is the author of the back in the lens technique, which is a novel technique that can be used in a variety of situations. But she also works on special lens that can be implanted for people with macular degeneration, which I think that is really one of the greatest opportunities that we may have in the future. But today we invited her to talk about the basics of the vitreoretinal surgery. And you have a link where you can see her biography, so I'm not going to talk about her. But I should say that what Marie-José said is such a wisdom that I always take note from. So Marie-José, the floor is
Okay. Suddenly the voice is lost. I don't hear anything.
yeah, also okay. My microphone.
Okay. So I suppose that I have now the microphone. So hello everybody, and it is really a really pleasure for me to have been invited by Professor Grobsheva, with whom I'm working now for many years in different settings and in different societies. And I always enjoy to work with her because she always is open-minded, open for new ideas, and not putting you aside if you come up with a new idea, which was often the case during my career. So what about retina? This is a course that I would like to present to you. I first start my disclosure regarding the consultancy agreement with TEA and with Siemer. I have also intellectual property in the back in the lens and ring caliper, licensed to Morsha. I will speak a little bit about it. And then I would also like to acknowledge my co-workers and my colleagues, dear colleagues, with whom I have worked many years together. And I think that as a person working in institutions like a university, you need absolutely nice co-workers on which you can rely, and that is absolutely crucial to progress. Now, when I do presentations, I like, certainly for educational purposes, I like to give the tribute to my mentor, because it's you make yourself for sure, but you only make yourself by yourself. You also need mentors. You also need people that you carefully have to choose during your life. And for example, one of my mentors is Charles Schepens. Although he was active in Boston in USA, he was Belgian originally. He came many, many times in Belgium, and we had a quite close collaboration between Antwerp and between Boston due to his roots. He was the person who helped me in order to start my career in vitreoretinal surgery in the 1991 years up to 1996, and then I switched more to the anterior segment. Another person that is really mentor regarding vitreoretinal surgery is Ingrid Kreisig. She is in fact a person who advocated the buckling technique very much. Why? She was absolutely a top person in a surgical procedure, very precise in her surgical procedures regarding buckling. I wanted to learn from her. I went to Tübingen where she was active, and I stayed in contact with her many years. We discussed many things on phone, on paper, on whatever, and during meetings and congresses, like you can see here in 1999, this was a congress in Stockholm. She was the life friend and intellectual collaborator of Linkoff, and we will speak about that later on. Another person that I would like to make a tribute of is Harold Rickley, a person that I met. I read everything about his work, and of course he was a good inspiration for me, because what he said and what he claimed already in 1954, I was barely born at that period, he said we need to solve the problem after cataract surgery regarding accommodation and PCO before we can say that we will do really progress. And of course, my mentor and my dear friend, Charles Kelman, whom I learned about the phacoemulsification, and of course, with whom I worked. He knew about the back in the lens. He was very in favor of it, but unfortunately died before he could witness the implantation in humans. And then another very dear person and mentor of mine is Daniel Aron-Rosa, whom was one of the inventor of the yak laser in the mode of the surgical mode. Although I have never used her laser system, I always used the system promoted by Van Kouser, which was a much broader way of approach as yak laser and surgical yak laser than the one invented by Aron-Rosa. So although I loved her, a good relationship with her, but I preferred the laser of Van Kouser. And I will speak a little bit more about that as well later on. And of course, another person that is really a mentor for me, I went to his lab, we worked together, we published together, is the Jan Worst from the Netherlands. And he is the one whom I worked with him in Groningen, and with whom I discovered the interface of the anterior interface, anterior vitreo-lenticular interface, also named the space of Berger. And this presentation, I will start with that, follow this, this little introduction of mentors, because all these people that you will have heard about, they have in fact made what is happening now. And that is the reason why I always like this history, because this is important to know. And if you need to have more information of some details, go back to the past, because often you will see that it was already written down. Here it is an eye that has been, on the left, it is an eye that has been dissected with, by myself and by Jan Bors on a young adult. He had a brilliant idea to dissect an eye underwater, but that was not his idea. But what was his idea? He's added on this technical procedure to do research was to use colors, and was to color specifically the areas of the vitreous and the spaces of the different vitreous. And here you see in the center a white coloration of an area. And what is that area? That is, in fact, the space of Berger, the retrolenticular space, or the space of the retrolenticular space, or the patellaris space, like it is also written down in the old books. Now, this was important for me because at that time I was thinking about the bag in the lens, and one of the biggest part of the bag in the lens, the posterior flanges and a part of the optic, was implanted behind the capsule. So I wanted to know whether there was a space there and whether that space was big enough. Although it was written down in the books of Wolf, Etienne Wolf of 1948, that the space of Berger was 9 millimeters in diameter, in the mean diameter, I wanted to see that. I wanted to objectify that. And this I could do with Jan Bors. The book of Berger described that space, the space behind the posterior capsule and before the anterior hyaloid. And this is in fact already described in 1887, but not used since then. Nobody think about that. Nobody was thinking about even the role. What was the role of that? See again, look again with me. Here you have the attachment, and here you have the attachment of the anterior hyaloid at the level of the posterior capsule. That means that this attachment is important. But being the lens and this space being immersed in water, and having that attachment, this attachment is of course also very important to understand about the accommodation process of the eye. If you lose that attachment, you lose also properties of accommodation, because accommodation is a hydraulic driven force. Not only, and I'm practically sure it's not only by the zonules, because the zonules are relatively weak. It is transmitted by the zonules, but induced by the water. I'm practically sure, but we have to prove that. Now, the bag in the lens is in fact based on that space, and I implant the posterior part in that space. Now, when you look at doing a PCCC, you will see that you will understand much better what happens here. I'm injecting viscoelastic. Look at the way the diffusion of that viscoelastic is progressing behind the posterior capsule. I activated it again. It's getting more and more, but very precisely behind the posterior capsule, filling a space. And that space stops at a certain line, the line here that you saw, and this is in fact the line of the Meagher's ligament. This is a young adult eye. So we knew it already without having the OCT in order to prove it. Only clinical observation allows you to see that there was a stop of the viscoelastic material, and that you could already know that there is a nice diffusion between two blades of the viscoelastic material. If there was not an anterior hyaloid, if there was not that space, the viscoelastic would tumble down in the vitreous and immediately fall in the vitreous cavity. It didn't do it, only in abnormalities or only if you have a rent or whatever. Now, with the advent of the OCT in the microscope in 2015, I was able to show that when I implanted the bag in the lens, I indeed implanted both capsules within that groove, and this is what you will see now. But it is also, I also could see that there was something else behind those capsules. And there was a little line behind that. But I didn't know at that moment what it was there. I was already very happy that I could show to the people that there was the possibility to insert both capsules, like you see here. Both capsules were inserted in the groove of the lens. But when finally after that it worked and I saw that there was no PCO, that I could go even with more complex optics, and then I redid a little bit the diagram. And I did a diagram based on what was known and also based on the normal biometrical parameters of the eye that we had based on a study, a European multicentric study that we conducted in order to know which are the parameters of all the biometrics of our anterior segment. And if you look at that very carefully, these are all the means that you can find in the literature based on a very huge work that Professor Jos Rosema did in our department. And then you see the real sizes of all the aspects. And this is the situation, lens of 4.4, and this is in fact the space of Berger, and this is in fact the Zonius anterior chamber. Okay, fine. Now do understand that when you take away your lens, you will reduce a volume that is more immense, very big. You will reduce it to a very small volume because the artificial lens that you're going to implant is small. What is that? That means that our anterior chamber, sorry for that. That means that our anterior chamber will be cast deeper, that our posterior vitreous area will also change in volume. And how will it compensate? Because this is a bidimensional image, but you have to imagine it in a three-dimensional space and area, and that's quite huge. The area that you have to compensate is quite huge. Now, with the back in the lens, I will push back the anterior hyaloid a little bit further to its original position by inflating that space. That means that with the back in the lens, you do not change that much that space, but we do not know how long it will last. But certainly what I can say that I give to the eye more time to adapt to this new situation and to adjust and to compensate for that change in the posterior area. I think, and we published that this is the reason that if you have a normal virgin eye, you may not have macular edema and you may not have retinal detachment after back in the lens implantation. And this is what we published. We have no CME, but we have retinal detachment in a little better incidence than what you have after lens in the back implantation techniques. Now, with the OCT, we were able to recognize the anatomy that Berger and that all the people described about that space, retrolenticular space. And this is in fact what I discovered in 2015. If you look together with me, we have here an eye that has been emptied from his crystalline lens. Anterior capsulorhexis is done, posterior capsulorhexis should still be done. And if you look at the two meridians of the OCT, let us follow here the blue one, you see the anterior capsule, you see here the posterior capsule, and you see here the anterior hyaloid. So so far so good. But what you observe is the anterior hyaloid is going and is prolabing and is coming close to the posterior capsule, following the posterior capsule. What you also can see is that the anterior hyaloid is attached to the posterior capsule, and this is, you can see it here at the blue line, but you can also see it here at the pink lines. What's happening is clear. We can observe it now and we can prove it. And here I'm inflating the space behind the posterior capsule, and you see very beautifully that space is filled with viscoelastic material, but the posterior capsule is still attached here to its posterior capsule. Ligament of Weger is there, is solid, is still present and can be observed. Here you even see the little puncture that has been done through which the viscoelastic material was injected behind the posterior capsule, inflating the space of Berger. So when you inflate the space of Berger after surgery, don't be afraid that you will have pressure rise. You just compensate for what has been emptied. See, I hope that you changed your mind and that you have understood what happened with the space of Berger. Now, variation of this space is now one of my issues of interest, but here you will see a case where you have a vitreous prolapse, and this has been published in 2016. As very first, we publish that we can observe an AVD, an anterior vitreous detachment, just like I said to you before. Anterior vitreous detachment also occur when as well as you have a posterior vitreous detachment. Very new, but what is the influence of an AVD on the retina, on the ora serrata? I do not know yet. But in order to prove to you that you have an anterior vitreous detachment, look, this is the anterior hyaloid, and there is no line that you can draw in your mind that can reach the posterior capsule, even not can reach the zonules. So in this particular case, this anterior hyaloid is very loosened from the Berger space, but also loosened from the hyaloidal zonules, and is attached still at the ora serrata, which is a very tough attachment. That is the only attachment that remains for life between the vitreous and between the retina, or if I can say so, there is no retina practically at the ora serrata. There is only the retinal base there, which is called the ora serrata. So this is very new, innovative concepts, and we have to think about what does it mean. I think that the anterior hyaloid and the attachment of the anterior hyaloid preserves the lens metabolism from whatever and keeps the lens metabolism intact. If you take away that structure by vitrectomy or by aging, you will have more problems with your lens that will develop more kind of cataracts. So interesting for those who starts the vitreoretinal. Keep that in your mind, although I cannot say with very much 100% certainty what I pretend. These are all hypotheses, but some of them are already quite well close to be proven. Now here I'm performing a puncture, and then you see it live, you see it really live, that there is no attachment at all between the anterior hyaloid and between the posterior capsule. A very, very big space there, but you will see that due to aging, and this is another concept that is important for the starting vitreous, by aging the vitreous will prolapse. And you see here that the anterior hyaloid tends to prolapse, and this is due to the liquefaction, the syneresis of the vitreous. So that means that there is a disintegration of the hyaluronic acid content in the vitreous. And important to know, you see, I pushed back the anterior hyaloid. no way that there is an attachment somewhere with the posterior capsule. Absolutely not visible here. So far, so good. Concept that is very important, the AVD. Now, in order to look at this one, I would like to give another interesting video that is for vitreoretinal surgeon, because this is a combination of a phaco and a vitrectomy from Tucker. Here you see that I inject Kenacort in the space, retrolenticular space, in the Berger space. And you see that the Kenacort stops at the area of the attachment. Proof again with Kenacort. Why did I use the Kenacort? Because Kenacort binds with hyaluronic acid and binds to collagen. Whatever collagen, whether it is 1, 2, 3, 4, doesn't matter, it binds to that. And that we know from the coloration at the level of the posterior segment. So here I use this, so the Kenacort, I implant the backing lens after having retrieved a big amount of the Kenacort so that I have a better view on the capsule. I insert the back in the lens, and I will continue with the vitrectomy combination that we started already very early, but which is really tremendously highly used by Klaus Eckert in Germany, by Eric Degnaud in France, and other people in Italy, but I do not know all of them, unfortunately. Now here you see the OCT images of that space colored with Kenacort. And you see that in these high myopic patients, you see the beautiful attachment of the anterior hyaloid to the posterior capsule. This is coloration to the remaining OVD, and that's the reason why you see it. Now here I have my vitrector, and you see that I'm pushing on it, and then I start vitrectomy, and you see that I start vitrectomy, and what I wanted to show is that can I release that attachment? And you will see that I want to release it, and I will never succeed. Look, I'm pulling on it. Posterior capsule goes out. I don't want to pull the posterior capsule out of the lens, so I don't insist. Very difficult to take away the attachment of the anterior hyaloid from the posterior capsule at the level of the ligament of Wieger. And Wieger himself already published that in 1883. So know your history. This is what I always repeat. Read it. You will understand that some processes and some principles were already known from the past. Now, it was Booker Dick that has the credit to have shown this space of Berger for the first time on femtosecond laser, fixated image, frozen images, but unfortunately on the femtosecond laser, it's only a one image. You cannot do it live, you cannot do videos. So he was not able to show the differences of the attachment, because in order to see whether you have an attachment, yes or no, you have to inflate that space. Only having an image immediately after having emptied the capsular bag from its lens content, you cannot prove that there is a detachment. This is also a mistake in a paper written by Maloghi that has had to be corrected when I reviewed it. It's not correct to pretend that you have a detachment based on just an image immediately after having emptied the bag from the crystalline lens. So these are all the publications that are related to this macular edema, also retinal detachment. We really reach better levels of incidence of those complications than the traditional lens in the back implantation techniques. Now, posterior vitreous detachment is, of course, also quite a very important item that you have to know, because the posterior vitreous detachment is the one that is connected to the retinal defect or Metagenous retinal detachment, and eventually the need for vitreoretinal surgery. So this is something that we have to know. The vitreous, well, the vitreous, we know it. I will not go too much in details, but you see this is in fact the image of Jan Worst. You see that he already took pay into attention the retrolenticular space that nobody took take up attention of. The attachment here, the ligament of Rieger is shown here, and then his peculiar anatomy of his features that in fact has been proven, and that's the way that I came in contact with him, is that after puncturing a premacular hemorrhage in the bursa premacularis, I showed that he was right, that in fact the blood came out of that premacular bursa and came in the remaining vitreous in another cisternae and not dispersed everywhere in the vitreous. But that's a detail, and I will not, it's too much to speak about all that in today's presentation. The anatomy of the posterior interface, we can look at it and we can see that there is here the posterior hyaloid is still attached, beautiful attached, normal anatomy. Even you can see the space of Martigiani here, defined by this septum between the space of the space of the bursa premacularis, of the space of Worst, and here is the space of Martigiani that was already described by Martigiani in the 19th century as well. Now, the issue is, and this was the reason why I am interested, is that that space of Berger has some issues. There may be debris that falls down in that space, and you see here in the images here superiorly, this is the space of Berger, a huge space, and some debris are there, annoying the patient tremendously. And here you see also, this is a cut here, a little bit more inferiorly. Look at what you can have as images that annoys your visual acuity. Look here, how opaque this vitreous is just before the retina. A really opaque, a sky of stars is in front of that patient every time, all day. Can you live with that? This is another type of floaters that have been described recently, and that corresponds to degenerations of the vitreous due to aging of the young adult, and mainly men. And why is that? Men have longer eyes than female for the same refractive error, have thus also bigger spaces of Worst. And then that's, I think, the reason. Now here you see even connections between the floaters after PVD, remaining connections with the retina. All reasons why people complaining with floaters, please take that in attention. It is a pathology of the posterior hyaloid in the young, and it is a pathology of the central vitreous in the elderly. So two kinds of groups. Now, when you do a vitrectomy for floaters, for example, here in this case, I will show it to you, maybe here. You will see very beautifully the anatomy. I would like to show it in order not, yeah, you will see very beautiful the anatomy. So here is the attachment of the space of Worst, that you have to consider. It is just like a hat of a professor, closed and attached only at a very central part there. And here you can see very beautiful the Martigiani space and the bursa premacularis. It is colored with Kenacor, it is colored with Triescence. Please use as much as possible the Triescence, because Kenacor may give some reactions in the kind of sterile endophthalmitis, but Triescence can give it as well. And here you will see at a certain moment, I will be able to detach, and you will see that the anatomy is really there. And you can visualize it so beautifully. And this is in fact a vitrectomy that I do, that I still do, and practically only do currently, because I'm interested in the floaters and because I'm interested in that interface that I would like to know a little bit better. I would like to show you the time where you will see the detachment. Maybe that I can a little bit further, because it's not the idea is not to waste time on too much of that video, but it is a very interesting. Look here, I have it. So here you see that everything is getting detached. That is, in fact, you see here, this is the big space of worst attachment, perifoveolar, perimacular, I have to say, and you see that it's big, very big attachment, but much smaller than the total space of the area of the bursa of worst. So beautifully, you can see it. Everything is now proven. And in fact, the PVD now, the real PVD is in fact an effect that occurs just due to two principles, the principle of the syneresis and the principle of the synthesis. The principle of the syneresis of the vitreous is the liquefying of the gel of the vitreous body due to loss of hyaluronic acid, and that is due to aging, just aging. And synthesis is in fact the collapse and the detachment of the attachment of the vitreous at the level of the cortex of the vitreous body from the retina. And it starts at the foveal area. These are the weakest attachment. It will then also come loose from the big vessels of the retina, but it will still remain attached at the level of the ora senata. Two big principles, aging principles, syneresis. And syneresis means loss of hyaluronic acid, but also means liquefaction of the vitreous, also means increased mobility of the vitreous. So then you have to think, if you see the wobbling effect of the floaters in the vitreous, the more the syneresis is advanced, the more and the higher the speed will be with which the vitreous will move in that cavity. This is in fact just the principles of the physics. Now the PVD prevalence, the younger than 50 years is about 10%, older than 70 years is about 70%. This is also important to know what are you going to do, when can you expect the PVD, and the age when you have the patients that can have PVD. Increased axial length increases the risk of early PVD, age increases PVD, ocular surgery, like for example cataract surgery, inflammation, etc. Now, what is important is that 50% of the patients with acute symptomatic PVD, that's not so many people who have that, they will have a kind of retinal tear. And retinal tear of acute symptomatic PVD with intravitreal hemorrhages, whatever they are, small or large, you will have a retinal tear in 70% of the cases. Important to keep that in your mind. The treatment, asymptomatic PVD, don't do anything. Symptomatic PVD, you wait. And you wait, and it is approximately, it should stop after 2-3 weeks. If it still continues and there is 2 months elapsing time after the first symptom, but no clinical abnormality at the level of the retina, there is nothing to be afraid about it. Of course, if you have a symptomatic bleeding, follow it up, and there will be most probably necessity of doing laser, of necessity of doing surgery. Now, the prevalence of retinal tear is also, there is a preference based on the quadrants of the peripheral retina, and 6% of all eyes will have once a retinal break. But that doesn't mean that they have complications of full-blown retinal detachment, doesn't mean that they have complications of ever having the necessity of have ever had a surgery. We do not have 6% of the population who had retinal surgery at all. So, where are the retinal breaks? Temporal superior in 60%, inferior temporal in 15%, superior nasal in 15%, and inferior temporal, nasal inferior, 10%. So these are approximately guidelines in order to know what you have to expect. Of course, also look very carefully at the periphery, lattice, nail tract, features, etc. This you can all find, and I guess that Professor Grudsheva, she has the authorization to keep this presentation in order to have, so that you can have access, because it summarizes really the minimum knowledge that you have to know before you start vitreoretinal surgery. Now, the types of the evolution of retinal break to retinal detachment is also very well discovered and described in the literature. Horseshoe tears, in 31 to 57% you will have an operculum hole. In 12.5% you will have an atrophical hole, and in 1.2% only you will have retinal detachment. Symptomatic, asymptomatic, superior, inferior, myopic versus emetropic, persistent vitreal traction, no apparent vitreal traction, and it is very prudent to say apparent, because it is indeed apparent, and you have, of course, some syndromal issues that will more be prone to develop retinal detachment than others. So these are all the factors that you have to look at in order to see the degree of risk that your patient has in order to develop a retinal detachment. Now, if you have an asymptomatic retinal break, but asymptomatic, there is no treatment except that you have evidence of vitreoretinal traction. Aphakic eyes, better look very carefully and observe it and treat it certainly by laser, for example. Symptomatic, you absolutely always have to treat it, and operculated holes, you also have to treat it depending on the persistent tractions. Laser photocoagulation can be done, and that's really not a big deal. Take it in the safe side. In the past, cryocoagulation, and it is still an option if necessary, can be done. Now, the hematogenous retinal detachment, there are two definitions of retinal detachment. A retinal detachment as such means separation of the neurosensory retina from the underlying retinal pigment epithelium by subretinal fluid. That is a collection of fluid, an area with a collection of fluid. A hematogenous retinal detachment means that there is a retinal detachment resulting from liquefied vitreous gaining entry through a full thickness break in the neurosensory retina. So you need to have a break, and you have to look for the break, and you have always, when you have a retinal detachment, first look at whether it is hematogenous or not. So you need to find the hole. We need to find the hole, well, I will stop that because that is not so important. The incidence is approximately spontaneous. I mean by that is there is approximately 1 out of 10,000 to 15,000 persons will develop a retinal detachment. So the prevalence is approximately 0.07 to 0.3% of the population, depending on the studies. Myopes are risk patients. Pseudophakic patients are risk patients. Ocular trauma is a risk. Syndromal patients are a risk. Contralateral retinal detachment, family history, and contralateral, even contralateral pseudophakic retinal detachment is a risk. So look also at the area. So you have the most important retinal detachment, superior temporal, then the superior or total retinal detachment is the next incidence where you find a tear at the 12 o'clock position. Inferior tear, you will have in 95%, and superior tear due to with an inferior bullous retinal detachment, you will find that in a small percentage. If you don't see the media, you can use ultrasound in order to find the retinal detachment evidence. And then it is very important to make a differential diagnosis between the hematogenous, the tractional, exudative retinal detachment. Your surgery will be different, and your medical and surgical approach will be different in all cases. So let us have a look at the vitreoretinal surgery more in detail. And again, here, let us look at the history. Before 1930 was just the time that Belgium became independent, no treatment at all was possible. The introduction of vitreoretinal surgery was done by Jules Gonnet. He was Swiss. He was Swiss, located in Lausanne, and he made his publication where he said, already then, said, locate, find the hole. So find the hole was already introduced by Jules Gonnet, but also he introduced the ignipuncture, which means puncturing by heat. And this was working in some cases, but of course not in the same incidence that we have now regarding the successful approach. We had to wait until we had some more insights about better evaluation of the clinic, and then we had to wait for that Charles Schepens, and it is after the Second World War, in fact it was during the Second World War, that Professor Charles Schepens met Pomerantsev, a physicist who developed together with Professor Schepens that indirect ophthalmoscope. And in fact, Pomerantsev was Jew, Schepens was not Jew, was Belgian. He escaped as resistant person in the Second World War. He escaped through Spain, went to London together with Pomerantsev, and remained dear friends till the end of their lives. Pomerantsev unfortunately died very early, and Schepens only died at the age of 94 years in 1996. But he is the one who started the mapping of the retina thanks to his indirect ophthalmoscope. Another person, that keystone person in the vitreoretinal surgeon is Linkoff, the person who was located in New York. He was an American, and he worked, in fact, in the buckling. He started, in fact, the buckling procedures. And later on, Schepens also used the buckling procedure and even had the company under his control regarding the manufacturing of those sponges. Now, Linkoff, the working person, and in fact the mental supporter also of Ingrid Kreizig, they were really the person who started the buckling procedure. And Linkoff used also the cryo technique, but the cryo that was in fact invented, using it in ophthalmology, was invented by a Polish ophthalmologist. And this to extract the crystalline lens out of the capsule. And Linkoff used that idea to coagulate the retina. So you see the collaboration, international collaboration of people made it all possible to evolve very quickly. And I cannot stress it much enough to say to the young people listening now today, please take contact. If you have ideas, whatever, take contact with those who you think may be helpful in order to help you with your ideas. Because, for example, the eclipse of the sun by the moon was the reason why the German Meyer-Zwickerath invented the laser. The burning of people looking at the eclipse of the sun by the moon caused burning in the retina, and he applied that to do the photocoagulation in 1946, also after the Second World War. Of course, his instrument needed sunlight in order to get photocoagulation. That was not very instrumental and very useful. And it lasted until 1975, when the Professor Esperance from San Francisco collaborated in order to make the handy lasers that we have now. It it is Machemer who developed the vitrectomy, and his engineer was a French one. His engineer was Jean-Marie Parel, who was in fact French, moved to the States, moved to Florida, and worked together with Machemer. But most probably, the Swiss Creatinopathy was the very first one. But he didn't write a patent because he was a humble vitreoretinal surgeon, Creatinopathy, and he didn't write a patent. Machemer did it much quicker. The Americans were much more prone to inclined to write patents. I know it because I visited Creatinopathy in Switzerland, in Belgium, and he was still very sad by the fact that he was the first and he couldn't claim it because unfortunately he was too late to write his patent. It was still a bad feeling in his heart, but in fact, I think that for me, he still remains the really inventor of the vitrectomy, of that modern vitrectomy. Now then the next inventor, if I can say so, is in fact a person who invented the oil tamponade. And the oil was in fact invented by Sabates. He was Greek, moved to the States, and he in fact published that in 1981. And working in Antwerp, very close to the Netherlands, where the famous vitreoretinal surgeon who introduced the oil in very severe cases of vitreoretinal surgery lived. I was very much, I had a tendency to use the oil very early in my practice, but I didn't continue because I worked much more on the anterior segment at that time. Now, very important is also Dr. Shang, who developed heavy liquid, because that's another tool that you needed to have in order to become much more successful in your surgery. And you also needed to have a system of how to visualize the retina much better. And that was Spitznaz. Spitznaz is a German ophthalmologist active in Bonn, and he was absolutely marvelous, and his contribution is absolutely great. You have to know that in order to know that the instrument, the recent development, that the development of vitreoretinal surgery as such is really recent, if I can say so. 1987 is really booming in the vitreoretinal surgery, and we know it if you look at the success of your retina. We know that it is really booming, not only for the surgery, for everything in the posterior segment. So really exciting developments are going on. So, in fact, illumination was important, visualization with the biome, the sutureless technique, 23, 25, 27 vitrectomy gauge surgery was necessary, and then the sky is practically the limit. Very excellent evolution. And of course, also the surgical modalities can be taught to the young people in a very, very educated way. And then for the young people, what you have to master is coagulation, positioning of the patient, pneumatic retinopathy, sclerose, buckling, pars plana vitrectomy. These are the different steps that you need to know in your education as young vitreoretinal surgeon. The pneumatic, the laser we have heard started with the laser of the retina, the right dosage, not too heavy, etc. These are all items that you will be taught during your education. Pneumatic retinopathy was introduced, in fact, quite in the 90s, but it's never been very successful. It's a technique that you have to keep in your mind. First of all, it was, of course, developed after the introduction of the gas injection, and it is most of the time, it is 0.5 ml of SF6 that is injected directly after having done a small cryocoagulation in order to protect the injection site. It is even not necessary to do it, but to try to reposition the retina. The only problem is that the success rate is not that great. It's only 80% compared to the surgical approach, which is much higher. But if you have no other ways of approaching and the vitreous is quite liquefied, you have already a detachment that is present there, or you can see it. You save some time. Sometimes. So limit indication, high reoperation rate, and final vision and anatomical outcomes are absolutely not bad, but maybe you lose sometimes in case of non-success, you may lose a little bit. The complications, here are the complications of pneumatic retinopathy, gas migration, always possible, intraocular pressurize. The patient cannot travel, not at all, not in the mountains, not in the plain. I may not die. Endophthalmitis, cataracts can be formed, IOL luxation, new breaks can be formed, vitreous incarceration in the puncture wound, very small risk, but may always happen, delayed subretinal fluid reabsorption, PVR may occur, macular pucker may occur, and whatever. So, not ideal in small indications, belongs to the armamentarium of the ophthalmologists, of the vitreoretinal surgeon. Scleral buckling now. Scleral buckling, you can use in combination with the cryocoagulation. Often you have to pay attention because cryocoagulation, in case too heavy, may give a release of retinal pigment epithelial cells, which on their turn will cause posterior vitreous, a proliferative vitreoretinopathy, and that is, of course, one of the biggest drawbacks of cryocoagulation. So do it always carefully, not much more than necessary. It is buckling, it is an explant. It consists of an explant. So suturing a segmental sponge in the radial way, in the limbal parallel way, or using an encircling element. These are all alternatives that can be done. Pay attention, intraocular pressurize, less than with gas, but still can be present. Myopic shift, fish mouth of the large breaks, bullous retinal detachment, and don't forget the myopic shift or even the astigmatic formation, which will result for a certain the astigmatism as such, which will decrease with time. The scleral buckling has a success rate of 90% of the attachment, which is already much better than the gas inflation. It is an extraocular technique, no cataract induction in most of the cases, lower equipment costs and less trained support staff is necessary, supporting undetected breaks when encircling. If you haven't if you are not sure about your drawing, you can do an encircling process, less strict positioning postoperatively. And the disadvantage just is that you have the diagnosis of the retinal breaks has not been done or not been illustrated very well or properly. Indirect relief of vitreal traction is not done, so it may be a prolonged subretinal fluid after surgery. The complications, we have said that PVR, we have said also the myopia, anisometropia, diplopia, all those angle closure glaucoma, all those kind of complications that you have to keep in mind. They're not small, certainly not small, so always weight it over the other aspect and over the other surgical procedure that is much more performed nowadays. People like more vitrectomy. It is technically easier to learn. Learning curve, I think, is shorter than the buckling. but also present, of course, like everything, its complication rate. So you are clearing all vitreal opacities with the vitrectomy, which is an advantage. It's a direct relief of the vitreoretinal traction, direct reattachment of the retina can be visualized. You need, of course, sclerotomies in order to have infusion, light and/or instrument. Not always, but okay, there is sometimes 2 weeks enough, very, very short vitrectomies. You can, of course, create a posterior vitreous detachment, which is a big advantage. You can, of course, due to the traction and to the PVD, you can cause new tears, and you can, of course, also you have, of course, to be as much as possible sure that you do not damage the vitreous base, because there could be contraction, could be caused of new tears as well. And the coagulation can be done, and air, gas, or silicone can tamponate the posterior cavity depending on the indication. The gas, you have to know, of course, the specific physical properties of those gases, very important. And the tamponade of SFSS, for example, will last for 10 to 14 days. So that means that never send a patient to the air or in the mountains before that period of 14 days. The C3F8 has a longer active time. Never send the patients also in the plain or in the mountains before 15 days, even 16 days is recommended. The indications and the complications, the indications for the vitrectomy with gas are mainly the rhegmatogenous retinal detachment with a break superiorly. Then the complications is, of course, the vision will be blurred immediately after surgery. It will last less longer than with the long-lasting gas in case of SF6. So that is also one of the reasons why SF6 is much more popular. But in case you want just to have a longer tamponade, you use the C3F8. And of course, you may cause retinal faults, and the intraocular pressure will increase. The silicone tamponade, you have different viscosities. The indications are depending, of course, if you have a rhegmatogenous retinal detachments and the patients want to fly, use them at all. The complications is that you have to remove it after 4 to 6 months or sometimes earlier. There is a cataract induction possible because you reoperate several times. There may be an oil block glaucoma. There may be corneal decompensation due to the silicone. There may be subconjunctival remnants of the silicone. There may be secondary breaks due to incomplete tamponade. So these are all the ones. Altogether, 90% of reattachment rate as well for single procedures. Advantages, I have told you that direct relief of the vitreal traction, clear media, direct reattachment, perioperative visualization of retinal breaks. Disadvantage, postoperative positioning, high or reoperation, time-consuming procedure, high equipment costs, and high trained support of staff members. The complications, I think that you know them all. Just a reminder here in order to be sure that you have it in your mind. The surgical indications, the pragmatic, uncomplicated superior rhegmatogenous retinal detachment, that is a summary. Scleral buckling, uncomplicated rhegmatogenous retinal detachment with few small breaks. Young patients, phakic and accommodation, do scleral buckling, preferably in order to keep the lens. Anterior, superior, or inferior located breaks are for retinal, can be chosen. Vitrectomy, complicated rhegmatogenous retinal detachment with separate multiple tears or giant tears, including sometimes even asymptomatic, pseudophakic, posterior located breaks, and recurrent retinal rhegmatogenous retinal detachment with PVR, with vitreous hemorrhage. This is in a nutshell the summary of the indications. Studies are going on, and I have been already terminated some in order to study better the indications, to be more precise and to give you better information to your patients and what is the success rate of which technique. Now, the prophylactic treatment of the fellow eyes, I think that this is also something that a young ophthalmologist has to be addressed for the young ophthalmologist. Don't forget that phakic fellow eyes need to be controlled very, very accurately. Certainly when you have fellow eyes of rhegmatogenous retinal detachment, pseudophakic or phakic ones, aphakic fellow eyes of a pseudo or phakic rhegmatogenous retinal detachment eye, aphakic or pseudophakic fellow eyes of pseudophakic rhegmatogenous retinal detachment, fellow eyes of giant retinal detachment, rhegmatogenous retinal detachment eyes, and fellow eyes of vitreoretinal sticklers presenting a rhegmatogenous retinal detachment. So all those categories of eyes do take care about their fellow eye. And please treat laser in a very moderate and very controlled way. The surgical outcomes, the anatomical general surgical outcomes, 90%. The retinal, the prognosis will increase for those who have a rhegmatogenous retinal detachment due to dialysis or small peripheral retinal breaks. Prognosis is less good for the rhegmatogenous retinal detachment due to giant tears, traumatic posterior tears, or associated with proliferative vitreoretinopathy. The functional recovery, most eyes with macula on and rhegmatogenous retinal detachment maintain preoperative visual acuity. The recuperation to best corrected visual acuity of more than 20/50 will be 87% of the ones with RRD and macula on, and 30% with RRD and macula off. Here are some literatures that are interesting, certainly important for the starters. And I also like to address that those who would like to know more about the anterior interface, we have written a book on that that came out on the in Springer's Nature. Thank you very much for your attention, and now it's again I give the word to Christina.
Thank you very much, Marie-José. That was absolutely fantastic. What a walk through the history of vitrectomy techniques and retinal detachment management, and actually your personal album is really like a history itself, because it appears that anybody who did something important was in somehow cooperation or personal relation in your professional career. So I think that this is absolutely fabulous. And the presentation you made is really one of the most comprehensive materials that I've ever witnessed in my career. So I think that especially my residents, they are extremely lucky that they had the opportunity to listen to this presentation, because it's a summary of everything that they need to know about retinal detachment and its management. But actually, for me, the most fascinating thing is how careful attention you pay to the retroreticular space and how you are investigating it. And really, I think that we've been quite along on this classic in the back technique, and we do not pay enough attention to what is going on behind. And in some patients, we have quite a lot of complications. Even in uncomplicated surgery, sometimes we have cystoid macular edema, which basically we need to address in the near future, because our excellent cataract surgery obviously is not working without vitreous body. So vitreous body is somehow involved. And this is really fascinating what you showed. I have a question to you, which actually is not my personal question, but from somebody from our audience. And this is in which cases you prefer vitreolysis with ocriplasmin, and in which cases you prefer to do vitrectomy?
Okay. Nice question, but I have to disclose that I never used microplasmin. I work in Belgium, and I know that the microplasmin, and I know the inventor of the microplasmin very well. He worked in London many years, but that the person who used it is Peter Stamans from Louvain, and he used that in some cases. I never used it, because at that time when microplasmin came in, was available, I didn't do so much vitreoretinal surgery anymore. Not anymore for retinal detachment, that was somebody else, and now it is Dr. Klaas who takes care of the vitreoretinal surgery together with Jonas van der Hurk in our department. So I cannot answer your question carefully. I must say that I have been involved in the evaluation of the microplasmin dossier regarding the EMA, so the European Medical Association. And I must say that when I read everything, microplasmin is not without any complications. In cases of very liquefied vitreous, it may damage the retina photoreceptors and retina bipolar cells. So pay attention. It has been described that there is a decreased contrast sensitivity in eyes where ocriplasmin have been used. So I have mixed feeling regarding that. And whether, okay, I know that it would be good to detach the posterior hyaloid as much as possible, but that's what I know, that there is also complications with surgery, vitrectomy surgery. There are some complications related to that. Even due to the vitrectomy, you can lose an eye. So that is, of course, important to weigh compared to decreased contrast sensitivity after use of ocriplasmin. And I understand that, but I can't answer you. So I think that also, again, if you want to have a reply on that, we need multicentric studies in order to study the microplasmin effect, vitrectomy, what is the benefit of the one over the other. Sorry that I can't answer you better than that.
Thank you very much. Can I ask you one more question? This time is from my side. I know that at the moment you're doing quite a lot of vitrectomies with floaters. What is your approach for very young patients that are having absolutely patent accommodation and that are having excellent visual acuity and everything is okay, except they have those floaters that are driving them mad? So what is your usual approach?
Yeah, I'm happy to that, Christina, to that question, because the floaters have been a point of interest for me for a long time, because I wanted to understand why I have two categories of patients complaining of floaters, the young one and the older ones. And then I was thinking, what happens there? Physically, I could understand that if you have black dots that you see as young patients, it must have been floaters located very close to the retina. Otherwise, you can't explain it. It's just physical properties. So I knew that I was close to the retina, but I couldn't see that because our own eye can't see them. And then I was so happy that with the OCT and looking at the interface, it was possible to objectify that, just like I showed you some examples of it. So my approach with patients, young patients who complain about floaters, getting crazy about it, is just to sit down with them, explaining them what is happening in their eye, and then I have a discussion. Can you live with that? I understand what you have. I know that it is something that I can objectify. I understand it's completely in relation with what you are explaining. But what I can do for you is not the yak laser, because I cannot reach those floaters with the yak laser. I only can do vitrectomy. Are you willing to do vitrectomy? And if we do vitrectomy, I personally do a lens-sparing vitrectomy like Jerry Sebag does. Why? Because I know the interface. And I know that if you have young patients, they still have a normal interface, not yet detached anterior hyaloid. So I want to keep that so that the metabolism of the lens keeps intact and remains the same. So I would like to see whether, and this is something that is absolutely interesting, is those who have had vitrectomy, lens-sparing vitrectomy, whether those patients have still an accommodation that is normal and better for the same age compared to those who have the age of accommodation but have lost their anterior hyaloid attachment. That's a very difficult situation to study. But I'm practically sure that all my patients that I do with lens-sparing vitrectomy, they still have a useful accommodation. When you have a patient who is between the early 30 till, for example, the end of 30, they are happy. They will not develop a cataract. Those who do, or where you do a lens-sparing vitrectomy and they are older than 40, they will need a cataract surgery a couple of years later because they will lose their attachment anyway. So I think that to know what happens and the discussion between what are we going to do is really a thorough conversation with the patients, the pros, the cons, and certainly the understanding. Now, I can announce you, and you are the first country that I will announce it, we started a new society, international society, that is the International Ophthalmology Floater Society. And that society comprises people from all over the globe. The board consists of people from Australia, from Canada, from America, from Europe, and mainly UK, no, not UK, France up till now, Switzerland, Belgium, and Germany. And these are members of the board, but we would like to expand everything. We will start webinars in order to discuss, advance, progress quicker, because what we have to do is to start multinational studies. So thank you for that question.
Thank you very much, Marie-José. I think that we have no more questions, but I cannot find the words to thank you for this really comprehensive review of the problem. And we hope to have you soon here in Varna, and we hope to see your back in the lens technique in our theater. We do have OCT, so you can make fantastic demonstrations. And I really would like again to thank you for your kindness, for your experience, for your role to the history of ophthalmology, and would like to wish you a very happy Christmas.
Thank you.
Very nice New Year, and hope to see you back in 2021. Thank you so much.
Okay, thank you very much for your invitation. Have a good day, all of you. Bye.
Bye-bye. Thank you.
Bye-bye.
Christina?
Yes.
Hello.
Hello, hello, Thomas.
How
Very nice to see you. Oh,
how is it going?
Behind you.
I'm good. I'm just coming from the busy surgical day as usual. I still have to continue to do some work today and have to go back to the OR in an hour or so, but I'm free for you now.
Excellent. Is this Frankfurt behind you?
Well, it's one of the pictures we put in there.
Okay, excellent. So I'm so glad that you are with us. We have 2 more minutes, but I will start introducing you, and then I'm going to give the word to you, and I'm sure that whatever you said, that is going to be fascinating, because these new developments with the EDOF lenses, I think, changed the cataract and refractive surgery world. And you're probably the person with most knowledge and experience in the area. So I think that sharing this with us is enormous contribution to our knowledge and our understanding. So I think that most of the audience knows you, because most of them are ophthalmologists, either very young ophthalmologists or ophthalmologists that already are having a little bit of experience. And we know you for years from your contribution to the Journal of Cataract and Refractive Surgery and to the Cataract and Refractive Surgery Society. And it is amazing that every meeting we have been, we always were witnesses of your new developments and your contributions to this meeting. And it's really a privilege for us to have you here. So as far as it's exactly sharp 1:30 Bulgarian time and 12:30 German time, I would like to invite you to give your insight on the subject. Thank you very much.
Thank you, Christina. Thank you very much. So let me pull up my slides. I think that's a very interesting thing we have today. I will go into my presentation mode. You can all hear me, I believe. And there we are.
Yes, we can hear you.
Okay, good. So, yes, of course, you introduced me. I'm working here at the Department of Ophthalmology in Frankfurt. I'm the chairman of the department. And I will talk to you today about EDOF IOLs, a new approach to presbyopia management. And I hope I can give you an expert opinion. Now, I consult for companies who have developed some of these IOLs over the years. You find my financial disclosures here. Many of them are consultant agreements. Some of them also, and many of them are also support for research, which we do here at the University in Frankfurt. And I also lecture occasionally. At the moment, it's all difficult with the COVID times, but we will go over this. Now, let me talk a little bit about the IOL overview and the IOL development. When we do surgery and we replace the natural lens, either as a cataract or as a refractive lens exchange, the normal way would be a spherical IOL, which corrects for distance only. If we look at the new areas, we have the premium or lifestyle IOLs, so in other words, lenses which can do more than a spherical IOL. And this is starting with an aspheric IOL, which improve optical properties in comparison to spherical IOLs. We proved this, I think, already 10 years ago, or more than 10 years, 12, I think the 2008 publication in Ophthalmology has shown that. Then we have the toric IOLs, which correct for astigmatism. And then we have multifocal intraocular lenses, which can correct for presbyopia. And we have a combination of all these things, like we have an aspheric, toric, multifocal intraocular lens. We still, and of course you can imagine that we are also working in the field of accommodative IOLs, but at the moment we cannot give you any insight of this because the development is undergoing, and many companies who are in this field have done this for many years and still are going to do this. Now, the area with multifocality I would like to highlight today is an area which I'm very interested in. It's bifocal intraocular lenses for far and near. We have the EDOF lenses, which are in comparison for far and intermediate. And we have the trifocal IOLs, which have far, intermediate, and near visual acuity. My experience goes back, you see, like 30 years now. that was the beginning of my area in ophthalmology. I started actually my residency in 1989, and I came into connection with the 3M diffractive bifocal intraocular lens at this time. And that was followed by a lot of intraocular lenses. Just some of you may recall the Resume from AMO, then the Ristor, then other type of lenses from different companies, trifocal lenses, quadrifocal lenses, and most recently also the EDOF lenses. So let me start with this here, the history of a diffractive bifocal lens. And I think it's interesting because we will touch the diffractive bifocal lens today a little bit more. And that is, in 2000, we started the journey. It ended 2012, more or less, with a plus 2.5 implant. If you see the addition, we started with plus 4, moved then in terms of material and in terms of construction of the intraocular lens to a plus 4 here. Then it was changed to plus 4 with a blue filter, followed by an aspheric surface, 2007. Then, according to research we have developed also with many colleagues, we found that the plus 3 edition is better. I'll show you in a minute. And then there came also toric versions on these platforms and the 2.5 low ad. Now, I would like to go a couple of my presentations, my publications. This is the 2006 ophthalmology paper, 9 sites. We had 127 patients, all with a plus 4 Ristor intraocular lens. And it's important to look at the defocus curve. We have the red one is the US trial. In blue is the European trial, which I was part of. And then we have in yellow, basically, the trials on a monofocal lens in comparison. What you see here is you have a distance focus and you have a near focus. And this was amazing at this time. We had 92% of patients would choose the same lens again after the first implant, and 95 answered likewise after the second implant. And we had still reporting 8.5 glare and 4.2 halos. And this was one of the downside of this lens. As I already told in the introduction, we came then a plus 3, and the plus 3 type of lens also showed this defocus curve, but the intermediate range here was less pronounced than in comparison to the plus 4. And this was so important because patients became happier with a plus 3 diffractive technology on the multifocal area. Then in 2000, I started 2012. These are the Trifocal Technologies 2020. There are several of the trifocal technologies on the market. Some of them are actually quadrifocal. And this is an area which changed the multifocal area very much because now patients didn't have that intermediate problem. And that changed the whole area in acceptance of the multifocal lenses for many patients. We had here an acrylisa trial, which showed the 54 eyes of 27 patients. We published this in AJO. And in AJO, 30 cataracts, 24 refractive lens exchange together. We had good visual acuity of basically a logMAR around 20/20. And we had very satisfied patients. 23 of 25 patients would have chosen the same IOL again because they had independence of glasses and 100% for distance, and in 12% only occasionally near corrections were used. And overall, because of this defocus curve, patients were quite happy because they didn't have the intermediate area and they were quite happy. There was only one downside, and that is if you look at the optical quality of those patients, we found glare in some of them, and we found halos in 60% of these patients. So we concluded that despite optical phenomena, patients were happy because that was our questionnaire. And again, here we had 12% use of additional correction, 12% in these patients group. And the patients were in these patients quite happy, although they had some optical phenomena. Now in 2017, this is a publication I did with my team on the Panoptix IOL, which shows here the demonstration of this lens. It has a quadrifocal type technology and has the distance at 120. So at distance at 120 centimeters, at 60 and 40. The change here is that if you distribute the light into 4 foci and then actually transform the second foci, or the first Purkinje here, into the distance focus, then you have the near visual acuity at 40 centimeters and intermediate at 60. That's different to a trifocal lens where you have this 80 centimeters intermediate. So this changed a little bit the defocus curve, and we found very good outcomes, 27 patients, visual acuity of intermediate and near visual acuity and distance visual acuity all around 20/20. So this is an IOL which I really like, although despite all that we have is we still see this optical phenomena in these patients. So in a couple of years ago, or I think it was last year, I wrote an editorial which had the title, "The Burden of Too Many Intraocular Lens Choices." And I think that's true, because we have now so many, and we have to really select them. And have said this, then on the trifocal business and the quadrifocal business, there came the topic of the extended depth of focus intraocular lenses. And there are several types, but all in common, they have excellent distance visual acuity, improved visual acuity in the intermediate range, functional near visual acuity, and optical quality and phenomena really depend on the lens design. And I would like to demonstrate this to you. So we have 4 different types of IOLs, which are shown here on this slide. There is this IC8, the small aperture lens, which works on a pinhole technology. There is the bioanalogic IOL, which comes from the Netherlands, not very often implanted. And then we have the big group of the Symphony and the Lara lenses, which are diffractive optics. They split the light and they extend it or elongate the focus. They do this, both do this, and I come to the outcomes later. And then we have the 4th group, and this is the very interesting group, and that is the non-diffractive optic with an aspheric design. One is from Italy, the Minivel, then the Lens Comfort, and then most recently the Vivity from Alcon. Now let's look at the ADOF, because that's the main purpose of the talk today. Here is, we have the small aperture IOL. Published data is very nice. They have a favorable visual disturbance profile. Remember, this is a monofocal lens, so they don't have diffractive technology, and they can actually prolong the focus. Therefore, the patients can have an intermediate or even a near visual acuity. They have not so many optical phenomena, and because of this pinhole effect, they can actually also mask astigmatism, which is very important. So they are much less dependent on small amounts of astigmatism than, for example, a trifocal or even an EDOF lens. It's a hydrophobic material, interesting technology. Papers published here, Burkhard Dick and his group, they published in JCRS, 105 patients implanted with the IC8 in one eye and an aspheric monofocal lens in the other eye. So it's a combination, it's kind of monovision principle. In 6 months follow-up, they found 99, 95, 79 of 20/30 or better for uncorrected distance, intermediate, and near visual acuity. 93 patients, which are 95%, reported they would have the procedure again. So that's also a very interesting design. There is occasionally also case reports. We found one here. We also have done it ourselves, that we have used this lens also, for example, for patients with optical phenomena on the cornea, for example, after a radial keratotomy. Now, the bioanalogic IOLs, as I said, less loose, but they have a depth of focus up to 3.5 diopters. It's achieved by a negative spherical aberration derived from the hydrophobic shape of the posterior surface of the lens, and they actually achieve the distribution, the elongation of the focus with this type of lens. So it's very interesting, but it's not very well worldwide used. There is this publication which I showed you. Here is the paper from Alios Group, 2019, American Journal, and they found this defocus curve, which is nice. It dips up here. You can see that you only have here the distance, and if you go to the near visual acuity, the control group had basically not as good, because that's a monofocal lens. So the intermediate and the near was better, but not as good as you can see this with a trifocal lens, for example. Now, I think the next three IOLs are the real diffractive technology which is used worldwide. The Technis Symphony was the first approved in the United States of a EDOF lens. They meet the FDA or the EDF standard criteria, increased range of vision and non-inferior distance visual acuity than a monofocal lens. They have a high percentage of patients which achieve 20/40 at near, so they have a functional near visual acuity. They have an increased rate of visual disturbances. That's a drawback compared to monofocal lenses, and therefore they also have a reduced mesopic contrast sensitivity versus monofocal lenses. And the inferior rotational stability of the Technics platform at that time was pointed out in the slide. This maybe has changed because of the change in technology of the construction of the lens. But nevertheless, you have a good distance, you have a good intermediate, you have a less near visual acuity compared to a trifocal lens, and you still have kind of visual disturbances. And that's the reason because you have a diffractive design. Although it's a diffractive echelet design, which is of course distributed from the company, which is a very good. We have implanted many patients with this and they're quite happy, but you need, and I come to this later, you need to talk about the near visual acuity. Here's another study, and that's a study from our group. We published that in Eye, showing the bilateral implantation of the EDOF. Uncorrected distance visual acuity was close to ametropia. Intermediate was also 20/20, like you see here. The uncorrected near visual acuity was 0.2 in logMAR, which is 20/25, maybe even less, 20/30. Spectacle independence, 100%, and 71 at near independence. So we had 30% in comparison altogether of patients who were using reading glasses with this type of lens. And again, we did our same questionnaire, which we did for all the trifocal lenses. And again, we found 54% of halos in comparison to our trifocal lens, which was 60%. That's very comparable. And patients reporting this as driving at night. And that's usually the downside of the diffractive technology, even if they are as an EDOF technology, and that was shown in our paper here. We also looked at the AT LARA, which is also a diffractive technology, different from the Symphony because it has a smooth microphase design, which should reduce the visual symptoms by minimizing light scattering. The aberration neutral aspheric design and advanced chromatic corrections is used also to improve the technology. But again, you have here some drawbacks, and that is on contrast sensitivity, increased risk of visual disturbances, but you have very good distance visual acuity intermediate. And we always find that patients usually need at least at one point some readers. Here's the study we are currently putting together. It's almost ready for publication for the EDOF type LARA. It's a plate haptic design, and we're also reporting the same thing here with a subjective optical quality questionnaire, and that is shown here. Again, we found at night driving a comparison of 0 to 6 in the questionnaire. Patients reported at night driving again some problems, and you can see here 87 in this patient group. It's a small patient group, but we also found halos here in this group with this diffractive technology. Now let's switch to the EDOF non-diffractive technology. The Minivel Ready progressive IOL shows here this design. It's an EDOF with this progressive IOL design, again demonstrating an extended depth of focus. This is the lens optic. This is the whole IOL, which shows the haptic design. We have a small published increased improved intermediate visual acuity versus the monofocal lenses. The published favorable visual disturbances profile in comparison to the diffractive technology. Toric are now also available. And we have monocular corrected distance visual acuity a little bit less than with monofocal lenses. And the contrast sensitivity seems also to be a little bit less. But overall, this type of lenses in the diffractive arena produce less halos. Here is the non-diffractive optic of the Minivel. bilateral implantation, defocus curve, best performs at 0 with 1 and 1.5 diopters in this range here. So you again have the distance visual acuity very good, but then the curve falls down, and you can see that there is also no loss of contrast sensitivity and a low risk of night visual disturbances with this type of lens. There is another lens, is the lens Comfort, LS313 MF15 with a +0.5 add, and again has a very different design, because you can see that there is an addition in the lens here at the lower part of the lens, and you can also achieve through this less visual disturbances, but you have a low add. This lens is also available with +3. This is the non-diffractive paper here. More than 95 patients were satisfied with the visual acuity, less than 10% reported photopic phenomena. What is interesting in these, and I try to figure this out for you, for the audience, that we have very satisfied patients, although they still need reading glasses. I show you in one of our slides that this is necessary because the uncorrected near visual acuity is 0.5. That's 20/40, but the patients still are very satisfied. And the reason is they have a low amount of photopic phenomena. I think that's very important. And we have here the +3. 50 eyes reported this also in the American Journal of Ophthalmology. And we found here the uncorrected intermediate and distance-corrected intermediate very good, less good. The near visual acuity, but again, very comparable. Now, I would like to go to the final design, which I think is a very interesting design. This is the non-diffractive technology. It's called the X-wave technology. They're using this technology, transition elements to transit elements to create advanced and a delayed wavefront. So the wavefront, which is produced from the IOL itself, this is the wavefront, which can be separated in an advanced and in a delayed wavefront due to the fact that this lens has on top this ring. It's very small. It's a very tiny area on the anterior surface of the lens. And therefore, you say you achieve an advanced wavefront collapse down on the intermediate to distance area, and you have a delayed wavefront collapse down on the near to intermediate area. And that is the reason why this lens has this long defocus curve. The toric lenses is already available. We have implanted a lot of them actually till last November. And I will show you here the comparison of a monofocal lens. That's the focus focal point of a monofocal lens. That's the one from the Symphony. That's all in a benchmark study. That comes from actually the Alcon laboratories. But I think I like to show this slide because it really demonstrates what I also feel is going on. And here you have the Microsoft Vivity X-wave technology with an elongated focus. And this is really an extended range of vision when you implant this lens. Now, let me show you here one of our cases. I think it's interesting for you to see also some surgery. This is one of my preferred methods at the moment. That's femtosecond laser technology with presbyopia correcting intraocular lens. I think it's very important that you have a very good capsulotomy, which I do here with a femtosecond laser. You found this. You can see here when you do the femto, you can see that now the separation of the nucleus or the fragmentation of the nucleus is done. That is going to be ended. And then what we see here is we have some laser keratotomies. We use them for correcting some parts of the astigmatism. And then we have here the main incision and 2 paracenteses. So that's the procedure. Now I'm going to, under my microscope, I'm open the incisions. I insert the viscoelastic substance. I take out the capsulotomy. I use my hydrodissection. You can see that the lens is fragmented. I make sure that the lens moves, and I do this here. Now, of course, I still need with a femtosecond laser opening, and we use a phaco tip, but I also can tell you that we have approximately in 50% of our surgeries when we do refractive lens exchange and the non-so-hard cataracts that we don't use any ultrasound anymore. and we basically take out the lens with our ultrasound machine. Here is the Centurion. Take out the lens and distribute very low energy into the eye, because we already have fragmented with the femtosecond laser. And we go now here into a higher suction mode. You can see this. We remove the lens. Maybe I fast forward a little bit here. We remove the nucleus, which I can do here. We take it out. And the next step is usually I do bimanual aspiration, irrigation of the cortex, which I'm now using for 20 years. I have developed this when I was a fellow in the United States with Doug Koch, and you can see that this allows you to remove the cortex actually in a circumferential way, and you don't have the problem that you cannot take out nucleus below the incision, below the main incision. And you can really easily take this material out, but still have this flexibility of changing the sideboards and be very efficient in taking out and cleaning the capsular bag, which you then need. Okay, the next step, we go forward here. I'm cleaning the capsular bag with some forced infusion, and now I'm taking my Vivity design lens. We still have this in the D cartridge injector. The lens come in the eye. You don't see in the beginning that there is a big difference. So I'm putting the lens into the capsular bag under viscoelastic substance. And if you see very careful into the center of this lens, you might see that there is this technology, but it's hard to see even for the surgeons. Only if I hold this lens in the right direction, you can see it. And I think I remove viscoelastic substance. Still, it looks like a monofocal lens, but now you see, depending on how I hold the lens, you can see this circular ring shape. That's the addition of material on top of the anterior surface of the lens, which is the basis for this non-diffractive EDOF technology. I'm using here, as in many cases, I think, a version. I have to see if this is a toric version or not. I think it's not a non-toric version, because otherwise I would see the dots. So that concludes the surgery. You can see very nicely at the end the femtosecond laser created capsulotomy. I'm really happy if I can achieve 100% coverage so that these lenses are stable in the anterior chamber and stable in the lens position where I left them. And I'm also very meticulous about the toric versions, because you'd like to avoid rotation. Now we are currently underway a retrospective clinical observation study. Actually is the prospective inclusion now of the outcomes, bilateral implantation of this eyewear, the X-Wave technology. We had no previous surgery, ocular surgery, no ocular pathologies at this point. And of course, we evaluate the bilateral implantation. What we found is uncorrected distance visual acuity here is quite high, 92% the distance corrected, uncorrected 38%, so there was some downside. So it always depends on how good you achieve ametropia. Then we have the 80 centimeters, shows in the 2020 rate 23, and the 0.1 logma, which is 2025 or even better, 62%. Then at 40 centimeters, you found this here. Let's look at the one a little bit less. Then you compare to it at the 80 centimeters, and then at the 60 centimeters, so what the Panoptix usually takes, there is less visual acuity, but the worst, of course, we found in the area where we have the near visual acuity. So the defocus curve looks like this, very comparable. That is the binocular defocus curve with standard deviation. So the demonstration of these curves really is very interesting. What we plotted here is our outcomes with the penfocal, with the quadrifocal lens, and with the monocular Vivity lens. And you can see that in blue, you see the trifocal lens. That's very nice, it's according to the natural curve. And in gray, you see the lens of the Vivity lens. And you demonstrate here, you can see that the visual acuity in the near area is not as good as with a really with a trifocal or quadrifocal design. The interesting thing is that the optical phenomena with this non-diffractive design are very minimal. 25% only reported halos, 12.5 glare. This is very low because you always have, even with a monofocal lens, you have this problem. But this is in comparison to our trifocal lenses, very intriguing. And when you've asked the patients for night driving, they actually don't see this as a high problem. They can night driving because they don't have a diffractive technology. Now they have a diffractive technology on the X-wave technology. So conclusion is the visual performance of this new non-diffractive extended depth of focus is easy to implant. As we know the platform, patients are very satisfied with distance intermediate and sometimes even with near visual acuity. They have almost no optical phenomena. Patient would choose the same IOL, and I think it's a very promising technology. As Christina already said, the EDOF is a very interesting technology. If you are interested in the data, I published this as a letter to the editor in the JCRS because we had not the study finished, but we wanted to bring actually the information already to the community that this is, first of all, the defocus curve, but you also have very low visual disturbances. Now here is the rate of my IOLs over the last, you see here from November 12th, that is when I started femtosecond laser. And I think this curve is interesting for you. We put here the EDOF lenses, we started in 2013, it went up till 2018. If you look at the trifocal and panfocal lens, you see it big decrease here, but basically a flat line in a high range. But you can see that the diffractive lenses went up 15, 16, 17, and now they fall down. And the reason is we have the non-diffractive lens EDOF type designs, which are here in purple, and they go up and they're almost achieving now at the end of 2020, our trifocal. So we have two groups of presbyopia correcting IOL, which we really implant on a very steady and almost day-to-day basis. The main difference between the trifocal and the EDOF lenses, this is a comparison of trifocal with a diffractive EDOF, is that the near visual acuity is not as good, but you have very comparable visual disturbances with these lenses. So I think that EDOF lenses are also there for general healthy eyes. Patients with higher visual requirements and a monofocal lens can have them. Optical phenomena compared on the monofocal IOL, like they do here. And I would say on the technology, spectacle independence for far intermediate is there, and good vision during everyday activities, but you need reading glasses in most of the EDOF lenses. Indications for presbyopia correcting IOLs. We use trifocal lenses in patients who really have clear corneas, regular astigmatism, healthy fundus, and a desire for spectacle independence. But they need to know that you have some optical phenomena and you have to explain this to your patients. Whereas the EDOF type of lens have in the diffractive arena the same areas. We have used them more also for irregular astigmatism. Beginning AMD drusen is really a question. And we started also post-refractive surgery. We published this just a month ago in JCRS, our outcome. We have good intermediate visual acuity, no dependence on glasses, so they sometimes need reading glasses, although I have seen EDOF lenses in patients who don't have reading glasses. But we see less optical phenomena if we use the non-diffractive designs. So for the EDOF, you have to differentiate between diffractive and non-diffractive. And I can tell you already the non-diffractive have a lower to no optical phenomena profile, which is very interesting, as Christina Gubcheva said at the beginning of my talk. Couple hints very at the end. Target refraction is multifocal lenses is emmetropia. EDOF lens is also emmetropia. You can also use micro monovision, dominant eye for distance and the non-dominant eye for 0.25 to 0.5 diopters of myopia. My take-home message for the diffractive versus the non-diffractive EDOF technology, and you have to differentiate that, is EDOF have a higher patient satisfaction. Of course, they also have an expectation because they come and want a presbyopia correcting IOL and they want to be, almost like always, spectacle independence. There are still some optical phenomena if you use diffractive technology. You can maybe use it more in the area of irregular astigmatism, beginning AMD, post-refractive surgery, but I think that is also even more true for the non-diffractive EDOF lenses. They give good intermediate visual acuity, but they do not have an independency of glasses. The diffractive have the same. They have a large range of IOL power, but they have optical phenomena, as we say. The non-diffractive have a lower range of IOL power at this point because they are just brand new on the market, but they have low to no optical phenomena, and that's the interesting take-home message: non-diffractive, less optical phenomena. I would like to thank you for your attention, and I think the purpose of such a seminar is not that I'm talking all the time. Of course, I'm very happy to take any questions from the audience and try to do my best to answer them. Thank you.
Thank you very much, Professor Kuhn. It was fantastic overview of what we have currently as a viability for correcting not only the refractive error, but also the presbyopia. And I think that in the future, we are going to have quite a lot of need for this approach, simply because we are going to have more and more demanding older people that would like to be spectacle independent. That was really very nice lecture. Thank you very much on behalf of the team from Varna and Bulgaria, because we have quite a lot of people that are not only from our clinic joined to us to our seminar today. I'm going to transfer the questions to you because there are two questions, and I would like to start with this relatively funny question. Imagine that you need to operate somebody who is either your mother-in-law or somebody very close, like your mother-in-law to you. Which lens would you prefer, considering that she has beginning of macular degeneration like macular drusen at the moment, and also she wants to have spectacle independence? And which surgical technique you would prefer, either manual or femtosecond?
Okay, that's a good question. It contains a lot of challenges, but I can answer this directly to you because I did it this week. I had to do exactly what you just answered. And let me start with this. When I do presbyopia correcting intraocular lenses, I really like to use my femtosecond laser. And the reason is I have always 100% sure the right capsulotomy. I have lower energy in the eye because the femtosecond laser distributes the energy into the lens. You have less power of the ultrasound, and that is even if you only spare 2-3% of endothelial cells, which we found. That's the difference. You have maybe the double amount of endothelial cell loss in harder cataracts. And then the femtosecond laser technologies, I have to say, are not only the femto, but they also have digital systems. And the digital systems are very important to correct your position of the incisions or to place the incisions. And also you have an advantage in the toric version. I have stopped basically a year ago to mark my corneas for the toric version of the toric lenses. And I have followed the route I did maybe 10 years ago, let's say 9 years ago with the eczema surgery. When we had the first cyclorotation trackers, I always marked the cornea because I didn't want to miss the axis, which I had to do with the previous version of the eczema lasers. But when we had the first really cyclotorsion tracking devices, we're using the Schwind-Amaris laser, we haven't marked the cornea. And I just did this a year ago with my femtosecond technology, and that is just a very effective way to correct astigmatism when you have to do it. I do from all groups, if I look just at my at my EDOF lenses as well as my trifocal lenses, I have always like in the range of 35% of toric lenses. And the reason is we correct every type of astigmatism in these lenses because we know that the presbyopia correcting lenses have to be astigmatic neutral, or almost. Half a diopter is acceptable, but not more. Therefore, we're using a lot of these toric versions of the lenses, and that comes up to 35%. Now, the question is, the friend, our family, or my mother-in-law. Let's put it this way: older people who are have the problem of having macular degeneration. Let's say they have some drusen. I would choose at the moment, because they also want to benefit from spectacle independence, I would choose a non-diffractive EDOF lens, because I have several advantages here. First of all, I have no optical phenomena, so almost no phenomena. So I don't have to deal with it. As a patient, we don't know what's going on in the future, how the macula changes. And also they are a little bit less dependent on the emmetropic outcome. Now, if I would have a patient who is, let's say, 60 and totally wants to be spectacle independent, wants to play golf, wants to have, is a tennis player, also reads a lot and drives with the car, maybe not so much at night, then I think the trifocal lens is a very ideal situation for implanting the lens, because the trifocal lenses really give you spectacle independence almost, whereas the EDOF lenses give you spectacle, let's say, less spectacle dependency, because they sometimes really need reading glasses, but you have less optical phenomena. And that's the main difference. And therefore, I try to put them in the right basket to give the patient the right IOL to make him happy.
Thank you very much. Just to follow on this question, in which situation you would use small aperture lens, like those type of pinhole lenses that are available?
Well, we use them occasionally. That's not our primary choice, because you have to know that if you lose these lenses, you also lose some light. So therefore, if you put them bilaterally, patients have sometimes problems driving at night because you have this black aperture. So it's usually more, you can do it bilaterally, but I think even in the study which I reported here, the dominant eye was a monofocal lens, and the non-dominant eye was the type of aperture. Now, that's not my preferred choice for treating presbyopia, but I like to use this lens in highly aberrated corneas. So, for example, a keratoconus patient or a patient with radial keratotomies, where you have a lot of aberrations and you can take the pinhole effect in order to take these aberrations out. And the patients can be very happy, but you still have to understand that you take light away, and that needs to be taken into consideration on the whole concept of your lens, and also particularly on the cornea.
Okay, thank you very much. There is another question for you from our audience, and this is your approach to a refractive surprise when you have your premium correction with desire for spectacle independence. And let's imagine that they are overcorrected with 3/4 of a diopter, so they need minus 0.75. And they're not happy with this, and this is their first time. What will be your approach to such a patient? And this is their reading eye as well.
First eye and reading eye. Well, if it's a reading eye, then you can learn from this eye, and you go for the first or second eye and get the patients, and you can test this depending on the situation. Is it a cataract or is it a refractive lens exchange? But you can test the near visual acuity, and you can test if you put in the dominant eye then an emmetropic result, and you have your surprise, so you can fudge your IOL calculation. And if this is a normal eye, you should be able to do this. Now, we work a lot in the area of IOL formulas. We have stopped using SRK, TAFE, Timulus, Hoffe-Q, all these older type of formulas. We basically going either artificial intelligence, the Warren Hill's IOL calculation. We're going for the Virgin's formulas with Graham Barrett's formula, because it takes into posterior surface. And we use also the Kane formula, because they have demonstrated much better results overall. So we try to get rid of our surprises. But if you have that surprise, I mean, you can have different choices. So you have an overcorrection. The patient is myopic. And you should work out, if the patient is happy with this eye, if you treat the other eye for emmetropia. So if that's the case, then the patient is happy. If, on the other hand, the patient will never be happy because you tried everything, even the other eye has been surgery, and you have an ametropic results, then you can do a treatment to the eye. So there is a lens exchange option, which is for 3/4 of a diopter a big thing. We can do it if you don't do it too late. The other option would be any type of other correction, and I'm preferring either an add-on technology. I'm basically taking 3/4 or 1 diopter of myopic correction for this eye and put an add-on basically add-on monofocal lens on top of it. Or you can also say take a laser. So you take an excimer laser. So that's very good if you have all these opportunities, and then I discuss the options with the patient and figure out what's the right way. But if the patient is not happy with the myopia, with this type of lens, then I think you have several options to remove it and to make the patient ametropic if you want that.
Okay, thank you very much. But you touched on an area which is very interesting now. If you have an add-off lens, and let's say the difference between diffractive and non-diffractive add-off lenses, would you choose excimer laser as a correction for those patients, and what will be the positive and the negative for it?
Well, I think that the excimer laser is an excellent option. I mean, if we don't do, you cannot do autorefractive in these patients, and you know that aberration measurements are not very good because the diffractive technology in the eye, spoils all these measurements. What you need to have is a very good optician who can do a good refraction, and we trust them because we're working with them for a long period of time. And if they tell me, and we see the patient is 20/40 with the outcome of -1, let's make it easy, the patient achieves 20/20, why not doing then an excimer surgery if the cornea is used to it? And I use both. I use the femtosecond laser technology. You can do a lamellar procedure, or sometimes I do, because it's a low amount, 1 diopter, I do a trans-PRK with the excimer. So either way, it depends a little bit what the patient wants. If he wants easy, quick, let's say visual recovery, then we go with a femto excimer surgery, and we produce a femto LASIK. If he doesn't care so much and has more time, then we can also do a trans-PRK. The outcome at the end will be more or less the same. You can also do a SMILE procedure. And sometimes you can also, if the patient doesn't want the cornea treatment, then you do the add-on technology, which I think is very good. If the lens, your first lens, is in the capsular bag, but it should be in the capsular bag because you use one of these edge design lenses and they need to be in the capsular bag. Otherwise, you get a pigment dispersion syndrome if you put it in the sulcus.
Okay, we have another question. I'm just reading it. That's why I'm a bit delayed. We have another question, and this question is, which is your preferred lens in case the patient wants to be spectacle independent, but they're vitrectomized?
But what's the what?
But they had vitrectomy before. So.
Oh, vitrectomy.
Yes.
Well, vitrectomy is again, I mean, my department does, 5 vitrectomies a day. So we see these patients. It really depends on the outcome. If it's a post, let's say, macular function vitrectomy, then it's much different from, let's say, a peripheral retinal detachment, and the macula is still functioning very well. So I think you have to really look in the pathology. But basically, the type of difference is that you have no vitreous when you do the surgery. But if the macular function is good, you can use trifocal lenses. That's not a problem. I'm talking about a good macular function.
Yeah.
If it's not the case, then you have to do something different. I would think that you can go in this area. Very often the vitrectomy eyes are, let's say, the retinal detachment eyes, and they are highly myopic or larger myopic, because that was the reason. And then what I see very often at the moment, we don't have the power of the, let's say, trifocal and sometimes even the non-diffractive EDOF lenses available at the moment, because, for example, the Vivity is only produced from 15 to 25 diopters. And therefore, I'm using very often at the moment in these patients, for example, the Lara, which is a diffractive lens and works very well for me, and the patients are quite happy. And we're also doing very well with the IOL calculation in these eyes, because we really go, 3 formulas in order to figure out, particularly the long eyes, to get an ametropic result, because that's the main thing. If you do presbyopia corrections, you need to think, the main thing in your brain must be, how can I achieve ametropia? And that you have to work on the formulas for the calculation. You have to work on the astigmatism. You need to correct the astigmatism. And if you do this, it takes some time to correct this, because you need to get some experience on this. You not only have to calculate it, you also have to do it surgically, correct? But then it's a very good, option. And I'm seeing more and more happier patients when I'm doing this type of maneuvers I'm just explained.
Thank you very much. There is one more question to you, which is, what is your opinion about the mix and match techniques, like using different technologies in both eyes? And what is your general feeling and your approach to it?
Well, I per se mix and match, and that the reason is I haven't done so many. We occasionally did them. But we did so many studies. You saw all our papers in AJO 17, 16, and now we're preparing the LARA, we're preparing the Vivity. So we always have a group of patients where we have bilateral ametropia, and that took us a long time. It's not that we don't do, more surgery, but how difficult it is to get a patient into a study, how difficult it is to get a defocus curve 3 times in a row. It takes an hour for each patient. So these studies are enormous, time-consuming if you want to publish them in a JCRS or even higher in American Journal on Ophthalmology. So you need a lot of work. These studies take, for years to get them published. Now, the mini monovision is one option, half a diopter difference. The monovision is also the type of mix and match. You can, let's put it this way. First of all, mini monovision, you can do it with different type of lenses. So let's say a diffractive symphony in one eye and minus 0.5 in the other eye, you get a little bit better outcome. So you can achieve maybe spectacle independence. If you want to mix and match, then I aim for, and I have done this in patients, I aim the better eye with a non-diffractive EDOF. Let's say my right eye is my dominant eye, presbyopia, want to correct it, I would do the non-diffractive eye, the dominant eye with a non-diffractive technology, and the non-dominant eye, I would do a panoptics. So I would like to give the eye which is more for near, I give him a trifocal lens, because that really increases the visual acuity. And the better eye for distance, I give him a non-optical system, or a system which has no optical phenomena. We need to study this. We need to come up with this paper, and we just ready for starting a trial like this, but it will take some time.
Okay, thank you very much. It was really fantastic. Just for that, I would like to ask you, in your opinion, in the next 10 years, like till 2030, which will be the option for presbyopia correction? The non-diffractive EDOF lenses, or some sort of accommodating device that is going to be developed?
Well, that's a good question, Christina. I don't know exactly. I cannot look in. Nothing is more difficult than to predict the future, right?
Yes.
Yes.
But if I think that from my knowledge, from what I hear, from what we have worked, and where, of course, I got connected to many of these companies who do the accommodative IOLs, it's a pretty difficult road, but it goes in a very good direction at the moment. So I wouldn't be surprised that in 10 years, we will have a range of accommodative IOLs which can do their job, at least in a different range of accommodation, but also have a major advantage because they don't have any optical phenomena. Because that's really still, for me, in the presbyopia correcting the Holy Grail, you can do a panoptics, but if the patient has an optical phenomena, and many don't have that, but some have it, and occasionally it's only a 2, 3, 4% when you do 100 eyes or 100 patients, and you want to figure out these 2, 3. So that's one major thing for me. So we're talking about quality of vision, we're talking about PROMs, patient-reported outcomes, how can we use them in order to figure out of these patients? I don't think that it would be wise only to take now, just a non-diffractive EDOF lens and put it in all eyes because they have no optical phenomena. Then we would have missed the opportunity with a fantastic lens like the Zeiss trifocal or the Panoptix quadrifocal lens to make patients ametropic at the moment. And in the future, we will have accommodative IOLs. I'm not so sure. I cannot tell this 100% when they will be on the market. But the main difference and the main advantage seems to be no optical phenomena. And the current system which develop have usually this double technology. You have a base lens, and on top of this, you put another lens which can accommodate or which can actually move. That's a very interesting concept. What I also have seen in some of them is they have very low PCO rate because they cover the whole capsular bag, and you can see 3 years after surgery, no PCO, which is also a major step forward. I think that is all very interesting, what we see in terms of this. And remember that the trifocal and even the EDOF lenses have one major advantage to an accommodative system maybe. You have presbyopia corrected through optics, and the optics will not change. So they can last for 30 years, 40 years, whatsoever. However, with all the accommodative IOLs, we still have to look at the development. They might work for a couple of years, but how do they behave after 5 years? We don't know that. So that's very interesting, and we'll keep a lot of open questions for the future. And it's a very interesting field. And I'm looking forward to the next 10 years to do the research in this area and to get an answer to your question.
Okay, thank you very much. Thank you for joining us at these very difficult times. COVID really made us believe that we cannot predict the future because something like this happens and we need to change everything around us. But we really hope that in the near future you will be able to travel and come and visit us in person. So at the moment, thank you for your fantastic seminar. I'm sure that everybody now knows a little bit more about the EDOF lenses and a little bit more about how to make a choice for lenses for their patients. And we really hope that we will be able to continue this talk and maybe talk next time a little bit about accommodative lenses. Thank you very much, Thomas.
Thank you. Have a great day and enjoy the weekend then.
You too. You too. Thank you very much.
Bye-bye.
Bye-bye. Така, колеги, има ли нещо, което бихме искали да обсъдим друго? Искам да ви кажа, че ако възникнат някакви въпроси, можем да ги задаваме на лекторите в писмен вид и те ще им отговорят в писмен вид. Това всъщност е последната тенденция в уебинарите. По-голямата част от големите компании започнаха да правят уебинари, в които въпросите се задават писменно и след това се публикуват с отговорите и по този начин се получава по-голяма чуваемост, защото вебинарите не са като тези срещи, които сме свикнали да бъдат персонални и понякога се получава едно недостатъчно добро разбиране на въпросите. Така че знаете как да зададете въпросите, ако имате желание. Аз бих искала още веднъж да използвам възможността да благодаря на професор Тончев. Професор Тончев е директора на нашия научно-изследователски институт. Той се занимава с невронауки от много години и така това е една от пресечната ми точка с неговата научно-изследователска работа. Окото така или иначе е част от невронауките и ние ще продължаваме да работим в тази посока. С встъпването в длъжност на новия Chair, който встъпи в длъжност през месец ноември, ще имаме така и една доста по-добра международна видимост и възможности за повече колаборативни проекти. Така че според мен бъдещето е пред нас, а защо не и наистина да намерим възможност за решаване на проблема с презбиопия чрез използването на акомодативни лещи, както преди малко обсъдихме с професор Фонен. Някакви въпроси, колеги, има ли, които бихте искали да зададем, да обсъдим? Ако няма, аз бих искала да пожелая наистина на всички един приятен късен следобед и разбира се приятен уикенд, като продължаваме по същия онлайн начин, докато имаме по-добри възможности. Благодаря ви много за вниманието.
Да спирам ли Wi-Fi?
Да, може да го спирате.
Да, Тенка, спирай го вече.
Добре, лек ден.